All right, so sensory alterations. So at the end of this teaching, we will be able to identify etiologies and perceptual, cognitive, and emotional responses to sensory deprivation and sensory overload. We will perform a comprehensive assessment of sensory functioning using appropriate interview questions and physical assessment skills. We will be able to develop nursing diagnoses that correctly identify sensory perceptual alterations that may be treated by independent nursing interventions. We will be able to describe specific nursing interventions to prevent sensory alterations, stimulate the senses, promote health literacy, and assist patients with sensory difficulties. And we'll be able to develop, implement, and evaluate a plan of nursing care to help patients safely meet individualized sensory or perceptual outcomes. We will also discuss post-operative measures that can help prevent complications after a cataract extraction, differentiate between open angle and angle closure glaucoma, identify medications that are contraindicated for patients with glaucoma, describe the two main types of age-related macular degeneration, and explain the vision changes that result from delayed or unsuccessful treatment of macular degeneration. So the exemplars we will talk about tonight will be the effects of sensory perceptual alterations, so sensory deficits, and then sensory deprivation or overload, cataracts, glaucoma, and macular degeneration.
Ms. Davis, can you switch the slides, please?
Oh God, I'm sorry. Yes. Sorry about that. All right. So imagine if you could not see, if you didn't have any visual sight, if you didn't have any auditory hearing, if you didn't have any sense of smell, any sense of taste, or any sense of touch. These things would greatly impact the way that you lived your life every day. Stereognosis is the perception of solidity of objects. It is their shape, their size, and their texture. Kinetic is your awareness of positioning of body parts and body movement. And then visceral pertains to our inner organs. The sensory experience does consist of two components that includes reception and perception. So sensory and reception is the process of us receiving data about the external or our internal environment through our senses. The senses that we use to maintain contact with the external environment are our vision, our hearing, our smell, our taste, and our touch. Sensory perception is defined as the process of selecting, organizing, and interpreting data from our senses into meaningful information. So our perception can be influenced by the intensity, the size, a change, or a representation of certain stimuli, as well as our past experiences, any knowledge that we have, and our attitudes or our beliefs. In order for us to be able to receive the necessary data to experience things in our world, we have to have a stimulus. A stimulus is an agent, an act, or other influence which is capable of initiating a response by our nervous system. We have to have that in order for that to be able to experience that. If an individual attempts to react with every stimulus within their environment, or if there is insufficient variety and quality of stimuli, that's when our patients can have a sensory alteration. So for some patients who are bedridden, they might not be subjected to as much stimuli as someone who is leaving their room multiple times a day, going for multiple tests. We need to be aware as nurses how this overabundance of stimuli or a lack of stimuli affect our patients. Patients that are in the ICU or critical care units most of the time suffer a sensory overload because they don't get a chance to sleep. The lights are always on. There's always beeps and bells and whistles and people talking. There's a lot to keep them stimulated. So we do see that in the ICUs and the critical care. Sleep deprivation is also something that we see because it's hard for them to sleep. And then also cultural care deprivation can also happen if we're not thinking about those cultural needs and helping to meet those needs. And I didn't turn it again. I'm sorry. All right, sensory alterations. So a sensory deficit is an impaired or absent functioning in one or more senses. Sensory deprivation is when a person experiences decreased sensory input or input that is unpatterned or meaningless. A sensory processing disorder is a difficulty in the way that the brain takes in information, the way they organize it, and the way they use that sensory information. It causes a person to have problems interacting effectively in their everyday environment. Sensory overload occurs when a person experiences so much sensory stimuli that the brain is unable to either respond meaningfully or ignore the stimuli. And like I said, we see that a lot of times in the ICU. All right, so some of the effects of sensory deprivation. So patients may have a reduced capacity to learn. So you might notice that you're doing education with your patient and they have a very decreased attention span. They can't stay on topic. They keep changing the subject. They're not making good eye contact with you. They're just distracted. They can't concentrate. They might have an inability to think or problem solve. They might have a problem with their memory, or they might have a decrease in their task performance. They might seem disoriented. They could even have bizarre thinking. They could have hallucinations or thoughts that just don't even make sense. You might see an increase in anxiety. They might have panic attacks. They might be angry, or they might be very fearful. Some patients can become depressed. They can become very lethargic and sleep all the time, not really interact with you like other patients do. They might be bored, and they could have an increased need for physical stimulation. So patients at a high risk for sensory deprivation are institutionalized patients, those patients that are confined into very small living spaces at home, patients who are on bed rest, or patients that are in isolation because they're not having a lot of contact with people. Patients with impaired vision or hearing, patients that have bandages or casts that can interfere with their vision or their hearing, or even those tactile stimulations. And then also your patients who have like affective disorders. So they close out the entire environment and they don't interact with other people. Patients that, let's see. Patients who have spinal cord injuries or brain damage, obviously they are not, if they have spinal cord injuries, they might not be, they're not moving around as much, they're not congregating with other family members, they might just be stuck in certain rooms, or they might be on rehab units, they're not able to just get up and move around like the other people could. Let's see, patients that are confused or disoriented, and then patients who take prescribed drugs recreationally, and those medicines that can affect the central nervous system. So what are some of the effects of sensory overload? Your patients may seem fatigued. Irritability is one of the ones that we see the most. They're extremely irritable. They might not even know why. They can be very short with you. They can just be angry, cranky. They might have anxiety, a decreased ability to perform tasks. So maybe you have a patient that has diabetes and you've been trying to educate them about using their needles and how to dial up their insulin and how to check their blood sugar. That effect of that sensory overload might come across to you as them saying, you know what, I don't think I'm going to be able to do this. This is just too much for me. I'm never going to be able to do this. I need to have a family member. That's a decreased ability for them to be able to perform the task. They're overwhelmed, and then that's how they describe it. Difficulty concentrating, and then muscle tension. High risk would be those coming from a very quiet environment with unvarying amounts of stimuli, and then they come into the hospital setting and everything changes so quickly. They're going in and out of their room for tests. They're in an area, maybe a little pod with 3 other rooms, and there could be 2 other patients who scream all night long, or they're on a nursing unit that's very noisy and the staff isn't very conscious about what's going on. So our nursing care needs to focus on reducing that stimulus, and we want to be able to help the patient gain control over their environment. So I told you guys before that patients don't have a lot of control over their environment, but there are some things that we can let them have control in that will make them happy. So if they're safe to and they want to sleep with their door closed, go ahead and make sure that their door is closed at night. We can do something called sleep hygiene. If they don't have to have vital signs every 4 hours, we can put a sign on the door that says sleep hygiene at night, don't disturb between 10 and 5 a.m. So as the nurse, you would still go in and peek on them because you want to make sure that they're breathing. But if you're not doing vitals, then you're not going to wake the patient up, and you would try and be as quiet in the room as possible when you're checking on them. If they need something to help them sleep, we can order them something to sleep. If they like to have a snack at night before they go to bed, we can make sure that they have a snack. Maybe their family members can bring something in. If they like to get a shower at night before they go to bed, these are things that we can do to help give them some type of control over their environment. So these are the 12 signs of sensory overload. This is not everything, but these are some of the main things that we see. So maybe a loss of coordination or a loss of balance. Patients can have their skin flush where it turns red and then they go pale. We see it in children where they refuse to do things. They're very verbal with what they want. They start to lash out. They become angry. They repeat things over and over again. Patients and children, adults and children can cry. They can have racing heartbeats. It can affect the GI system, so they can have nausea, vomiting, or cramps. They could be sweating. So this is just an example of some of the things that we see. So this is just a little poem about...
Davis, can you elaborate even there?
Yes. So this is just a little poem about sensory overload. You guys can read over this whenever you want. You're not going to be tested on it. It's just something cute that Dr. Ertwein found and put in there. All right, so what are some common sensory deficits when we talk about vision? So an impaired or an absent functioning in any one or more of our senses we call it a sensory deficit. For visual, we have presbyopia, which means you're farsighted. You can have a cataract, which is a cloudy area in the lens of your eye that over time leads to a decrease in your vision. You could have glaucoma, which is increased pressure within the eye that causes a gradual loss of your sight. You could have diabetic retinopathy, which is caused by diabetes, and it causes changes to those blood vessels in your eye, which of course causes a change in your vision. And then macular degeneration, which is blurred or no vision at all in the center of your visual field. All right, so some hearing impairment, we can have presbycusis, which is hearing loss that is associated with age. And then we can have cerumen accumulation. So this is pretty common in the primary care setting. A lot of our older patients will come in and say, I think I'm having a loss of hearing. I just can't hear things the way I used to. The first thing the primary care physician is going to do is try and clean out those ears. A good percentage of the time, that is the issue. And then it needs to be done on a regular basis. If not, then they would be sent to an ENT and they would be evaluated for how bad their hearing loss is, and then maybe some hearing aids. Then we have issues that can alter our taste. So xerostomia, which is a decreased salivary production. It causes thicker mucus and a very dry mouth. Things that we can do to prevent this in our patients or to help with it is make sure that they're getting good oral hygiene. So making sure that they're brushing their teeth every day, making sure they have the supplies in their room to brush their teeth every day. And then peripheral neuropathy. So this is numbness and tingling or paralysis, which can result in altered perception. So we see one of the most common disease states that we see peripheral neuropathy in is diabetes. This causes them to have numbness and tingling in their feet and their hands. It's very common when patients have uncontrolled diabetes that they get sores on their feet because they have an injury or they step on something and they don't know it because they can't even feel it because they don't have any feeling anymore. So that's why when those patients come in the hospital and we're doing those, our fall risk assessments, we're asking about that numbness and tingling because those are some of the issues that contribute to them being a high fall risk. So factors that influence sensory stimulation. So there's always developmental considerations based upon your age. There's cultural factors, there's personality and lifestyle factors, stress and illness, and then of course medications also play a factor. All right, so when we're talking to our patients, we want to, part of that assessment is we're going to assess their sensory alterations to see if they have any issues. So you would want to assess their level of awareness. So you want to look at their level of consciousness. Are they alert and oriented to themselves? Are they alert and oriented times 4? Do they know themselves, their date of birth, what day it is, what month it is, what year it is? What's their memory like? Do they have any short-term memory loss issues, any long-term memory loss issues? Can they participate with abstract reasoning? And what kind of language do they use? If you suspected that they had a decreased level of consciousness, you could, or a decreased level of awareness, you could perform that mini mental status exam on page 1721. You can see a good example of that mental status exam. Physical assessment, we're going to do an ear and an eye test. We want to always check their ability to perform self-care. So some deficits may limit a person's ability to perform those everyday activities safely. So we want to recognize those patients who are going to have issues when we send them home in their home environment. Because if they can't do it in the hospital setting, and they don't have anyone at home, then that's going to be an issue. So we need to advocate for those patients. We want to talk about their health promotion activities, any environmental hazards, anything that could, maybe metal workers or iron workers, are they at risk for getting any kind of metal in their eye? Do they work in a place where there's a lot of loud noises or explosions, things like that could cause them to lose their hearing? And then we want to look at their communication methods. So how are they communicating with us? Do they have any type of expressive or receptive aphasia? Can they communicate okay? Do they have to have sign language? Do they need to have Braille? What kind of communication methods does your patient need? Then we want to look at any social support that they have at home, so we know that when they go home that they're going to be supported. Do they have any assisted devices? So do they have eyeglasses, contact lenses, hearing aids? These are all questions I ask my patients all the time when I admit them to my unit. How's your vision? How's your hearing? And if they tell me that it's altered in any way, then I ask, do you wear glasses or do you wear contact lenses? Do you have hearing aids? Other factors that you would want to think of, you would want to do a medication history, because there are certain types of medications that can decrease your sense of awareness or your awareness to sensory stimuli. So those narcotics, certain sedatives, they're all going to decrease that. Antipsychotics can also influence how we perceive our sensory and how it's processed. And then there's other medications that can contribute to the impairment of sensory functioning by decreasing our reception. And some medicines are also ototoxic, which can cause hearing disorders. So some of the nursing diagnoses we might use are impaired verbal communication. So this would be your expressive aphasia. Impaired physical mobility, self-care deficit, disturbed sensory perception, social isolation, disturbed thought processes, risk for injury, altered environmental stimuli. It could be excessive or insufficient. Anxiety related to paranoia, which could come from hearing impairment, sensory deprivation, sensory overload, and then impaired social interaction related to inability to receive and process interactional stimuli. So therapeutic nursing interventions. So we, when we're looking at health promotion, we're going to recommend that our patients go for screenings. So hearing impairment screenings, eye screenings every 2 years, or however your doctor recommends them. If they need any assistive devices, so do they need hearing aids? Do they need glasses? We want to make sure that our patients are involved in meaningful stimulation. So if for vision, we can use visual devices to help keep them oriented. So we can make sure that they have a clock on the wall. We can make sure that they have their watch if they came in with a watch. We can have calendars in their room. We could bring them a newspaper every day. We could turn on their TV and put on the news. So these are all good sources of them being able to see things that can help them in their environment.
Ms. Davis, I'm sorry. So the hearing and eye screening that's every year, this is only with older patients, right?
Nope, it's for anyone who has vision problems.
So this is any age, okay.
Any age, yes. Thank you. So there's a couple people that do not have their cameras on. You guys need to have your cameras on while we're in this lecture, please. Okay, so if you don't have them on, you need to turn them on, and please keep them on. We can also use crossword puzzles and different games to help stimulate mental activities. You can position patients with impaired mobility close to a window during the day. So that way they can look outside, they can see, depending on where that window is, it might face another unit, they can see traffic on the unit, they might be able to see a nice garden outside or cars going by. That is also stimulating. If we have a patient that has hearing issues, we can speak in a very warm, pleasant tone and communicate to the patient that we're caring. Avoid speaking about the patient to others within the patient's hearing, because it makes them feel like, because of their disability, because they can't hear, that they don't have an input in their care and that they feel less important. We can use television and radio to help keep them current and to stimulate mental activities. Make sure that we're keeping things turned up so that they can see them. For taste and smell, we can encourage our patients to experiment with food of different tastes. So we can add different seasonings, stronger seasonings that might help with their taste buds. We can offer different colors, lots of fruits and vegetables in their diet to make it seem more appealing. You do want to be careful with temperatures, making sure that it's not too hot, because if they have impaired taste and senses, then they could obviously burn their mouth or their lip or the inside of their cheek, and they might not know it. Textures are an issue for some patients. Some patients, especially that are on CHOP diet or mechanical diets, they often have poor intake because they don't like the way it feels in their mouth. It feels like baby food and they don't like it. So that can always be a challenge. Let's see, as patients get older, our taste buds change. Things don't taste the same as they used to. So they might not have a love for the same food that they used to their whole life. So just educating them and letting them know that is helpful. Make sure we're practicing good oral hygiene with our patients when they're in the hospital, encouraging them to do that when they go home, making sure that they go for regular dental exams, make sure that they have what they need to be able to chew food. If they have missing teeth, maybe they need to look into getting partial plates or dentures, things that will enable them to be able to eat a variety of food. You can consult the dietitian in the hospital to talk about preparing meals that have different tastes for the patients that make them more attractive. And then you can make sure that you decrease or eliminate any odors that might be foul or disgusting. So if you have a patient that had a bowel movement, you can bring spray into the room, keep it in there, give it to them, and they can use it. And then just be kind of aware, especially like I know with my hospital, we have like 4 little rooms right next to each other in like a little area. So if one patient has a bowel movement and they go to the bathroom, well, then all the 3 other patients can smell it. So just kind of be a little aware of that. Keep the patient's room well ventilated if you can. Use opportunities to take the patient out of the room, take them outside. It's kind of hard to do that in a hospital when you have 5 patients that are really sick, but in long-term care settings and rehabs, it's a little bit easier to do that. When you are changing your patient, so if you're changing a patient that had loose diarrhea or they had a lot of urine output, you don't have to put it in the trash can in the room. Sometimes I will keep little trash bags outside the room and I'll bring one in with me, and then I'll put it in there, tie it up, and take it right down to the dirty utility room. So that way the patient doesn't have to smell that, because we wouldn't want to smell that. So we kind of have to think about that, about our patients as well. If you change any dressings that are bloody, that have pus or any kind of drainage on them, you can do the same thing. Put them in another bag, take them down to that soiled utility room. When we talk about touch, so you can, especially for your older patients, they like to touch different things. So at my work, we have something called a busy blanket, and it's like a little, looks like a little apron, and it has zippers and buttons and different, little crinkly things that make noise, a little scratchy section, a really soft, like little tabs that come off of them. One's really scratchy, one's really soft. Sometimes we just give them little pillows that they like to hold on to when they're in the room. You want to respect your patient's need or desire to be touched or not to be touched. So some patients like it when you put your hand on them or you rub their shoulder. It's very comforting to them. That's how I am. If I'm in the hospital and someone does that to me, it makes me automatically just feel at ease. Even if they don't say anything, it just makes me feel comfortable. Some patients, especially in different cultures, it is a sign of disrespect and they don't like to be touched. So you really have to, kind of feel your patient out to see how they feel about that. You can use that physical care time when you're bathing your patient to really take your time, give them a back massage if you want to, When you're turning and repositioning them, putting lotion on them, making sure you're doing passive range of motion. That is all ways of providing tactile stimulation. So there's a lot that we can do. We can do stuff with different sights and sounds, different smells in the room, different textures. We can have music therapy. Sometimes there's pet therapy. Most people love to pet a puppy. It makes them feel good. These are all non-pharmacological interventions that we can do. Sometimes lighting a candle, playing comfortable music, getting into a new position, any kind of stuff like that is helpful. You just always want to make sure you're establishing a safe environment for your patient. So if they have issues with vision or hearing, you want to make sure that the bed alarm is on. You want to make sure that their call bell is in reach. If it's a vision impaired patient, put that call bell in their hand. Try to tell them where the buttons are on it. Sometimes what I do with patients who have really impaired vision is we have these little round circles. We call them telemetry leads. We put them on their chest. And we hook our monitors to them. Well, they have like a little raised bump that we actually connect the monitor to. I take one of those little round tabs and I stick it over top of the call bell, because if they put their hand on the call bell, then they can feel that little bump. And I tell them that if they hit that will get them in touch with the nurse. So sometimes you just have to be creative. But you want to make sure that things are close to them, put those bed alarms on, anything that they need to keep them safe. So we also want to prevent sensory alterations. So we want to control our patient's discomfort whenever possible. Whatever we can control, we want to try and control. We want to offer care that will enable our patients to get rest and comfort. So we want to think about clustering our care that we have to do, being conscious of that when patients are going for multiple tests. I had a patient the other day that literally had to go for 5 tests, and they wanted to get him back to back to back. So first he went to echo, and then he was going for a vascular duplex, and then they wanted to take him down to cardiology to do something else. And then I had remembered by the 3rd appointment that they called me for that this man hadn't even had breakfast yet. So after his 2nd appointment, I called out and I said, the patient has to come back. I said, you can grab him after he eats breakfast around noon. And the patient was extremely appreciative of that because he was starving. So yes, they are in the hospital. They need to have these tests to get better, but we also want them to have their basic human needs met, and that is food and fluids. So just kind of thinking about that, be aware of any sensory aids that they need. So don't come in the morning and start talking to them about medications or teaching if you know they have hearing aids and they're not in yet. We want to make sure that their hearing aids are in and that they can hear. If they need their eyeglasses to read over their discharge instructions, if they have any prostheses that they need, if they're going to be working with physical therapy, make sure that they have everything they need. We can use those social activities we talked about to stimulate the senses and the mind. This is more common in the long-term care centers where these patients can all congregate like in a common meeting room and they do different activities. We can also enlist the aid of family members, get those family members to participate or encourage their loved ones. We can encourage physical activity and exercises. So getting our patients up out of bed, have them walk around the unit, even if they, things have changed because of COVID, but they can still put on a mask and they can still walk outside of the room if they don't have COVID. They just have to wear that mask. And then provide as much stimulation for as many senses as possible. So for our patients that have vision issues, we want to make sure that we identify them when we're walking in the room. If you walk in the room and you just stand next to the bed and then call their name, if they really have a bad vision impairment, you're going to scare them. So what I always do is I just knock lightly on the door first so that they hear that. And then I'll say, hi, Mrs. Jones, it's Trish. I'm going to come in your room and talk to you for a couple minutes. Make sure that you really explain the procedure that you're going to do, more so than someone who doesn't have any vision issues, because they're not going to be able to see. So you really need to make sure you're explaining everything that you're doing right before you do it. Try and orient your patient to the room. So you can tell them, you know, at 9 o'clock to your left is your sink. 12 o'clock midnight is where your television is. Your trash can is over here at 3 o'clock. You can use the clock. That's a good way to make patients understand. Make sure you're standing at the front of your patient when you're addressing them, not off to the side. It's okay to touch the client to get the client's attention before you begin to perform a physical assessment, especially if their vision is not very good at all, if they're legally blind. So that way they know you're close to them, makes them feel comfortable. If they wear glasses, make sure you keep them clean, especially these older adults. I feel like they don't even realize, I don't even know how they see out of their glasses sometimes. I feel like I do this almost every shift, if not at least once a week, because they have food all over them and it's terrible. They can't see it. And then when you do clean them and you put them back on them, they're like, oh my God, it's like a whole new world. So little things like that are very, very helpful. If they're going outside and they have any kind of major eye issue, make sure that they're wearing their sunglasses. If they have a problem with seeing, you can print their discharge instructions in larger print. You have that option. You can encourage them to use a magnifier. You can offer, sometimes there are books that they can get that are on tape that they can listen to. And then encouraging your patient not to rub their eyes because that can cause an infection. So this is the clock method that we use when we're telling our patients, when we're setting them up to eat. You would tell them that their main course, if in this case they're having turkey, that is straight ahead on their plate at 12. They have green beans to 3 o'clock, and then they have a baked potato at 9 o'clock. So that's very helpful. All right, so hearing. We want to, let's see, when we talk to our patients, we want to make sure that we speak clearly in a lower tone of voice. You don't have to scream extremely loud for every patient that's deaf, especially if you're talking in front of them, because they're really, really good at reading lips. Make sure you're standing in front of them so they can read your lips. Make sure when you go in that you mute any background noise. So mute their television, turn down their radio, other things like that. Make sure that your lip movements and facial movements are visual, so that way they can see them. Use sign language if you know it, or you can, if that's the only way they can communicate, make sure that they have an interpreter there for them. If they don't have one in the hospital that can come to the room, they have one on your computer that you can pull up. You would just have to bring your computer in and get them on the screen, so that way they could see them and then you could communicate with them that way. And then you can always write notes. Notes are very helpful. All right, so we want to make sure that our patients that have hearing aids, that they are wearing them, making sure that they're working, helping them turn them on, making sure that their batteries have been changed. When my patients come in and they have hearing aids, the first thing I ask them is, do you have extra batteries? If they say no, I'll say, can we contact a family member and have them bring some extra ones in? Because we don't want you to run out and then not be able to hear us. It is possible to amplify their television and their TV, the TV and their telephone, so that they can hear better. You can use different alarm clocks that flash different lights and that talk. You should not chew gum when you're talking with these patients, or cover your mouth, or turn away, because patients that have hearing deficits have learned to be able to read your lips, and those couple things will impair them from really being able to understand what you're saying. If it's a temporary hearing loss, it could be conductive in nature due to the problem with the external or the middle ear. It could be an ear infection. It could be wax buildup. There could be a foreign body obstruction in there, and they could just have an infection. So those are the things you should try and rule out first. and recommend that they follow up with the doctor to see if it's any of those issues. Okay. All right, so taste and smell. Again, we want to make sure that they have good oral hygiene. It is recommended that everyone brush their teeth 3 times a day. That's probably not very realistic, but at least once or twice a day is going to be extremely helpful. You can season their foods with a variety of different spices so that you can enhance the taste. This is something that we do a lot with patients that have chemotherapy because it really alters their taste for certain foods. So they have to be pretty creative in order to get to taste a lot of different things on their foods. Be careful with textured foods. Some textures are good, some are not, especially with those mixed or chopped diets. Most patients are not a fan of those pureed diets. They think it tastes like baby food. Remove unpleasant odors. Example we gave again, if they go to the bathroom, if they have a bowel movement, if there's something dirty in their trash can, make sure that you're spraying and removing that stuff out of the room. You can use aromatherapy. It will help decrease stress and it will make the room smell nice. You don't want to mix foods because if you keep them separate, that way they can identify each taste. And then you want to offer foods that are appealing to the patient. So this is very important in the hospital setting. I see that there are some patients who might not be able to order their breakfast, lunch, or dinner on their own, maybe because they can't hear, maybe because they're just a little bit confused and they can't just follow the sequence steps that are needed to look in the menu and pick up the phone. But if you go into the room and you ask the patient what they feel like eating, or you give them the menu, they can tell you. But what I see happen a lot is that patients automatically get put on what they call a house tray. So instead of them being able to order their food for all 3 meals, the cafeteria just brings something. Well, they might bring something that the patient doesn't like. That could happen for breakfast, lunch, and dinner. And then the patient doesn't eat anything. And this has a huge impact on their nutrition status. So you want to offer the patient something that's appealing to them at every meal. So take that extra time and make sure that you are that nurse that asked your patient, let me help you order your breakfast this morning. What would you like? Tell me what you usually eat at home. You might have to make maybe they usually eat fried eggs and bacon at home. Well, if they're there because they have congestive heart failure or high blood pressure, they're probably going to be on a cardiac diet. They might not be able to have that, but you can work together with the patient to find out foods that would be appealing to them. So then we want to talk about touch. So we want to make sure that we're protecting our patient's skin from extreme temperature. So if they are extremely hot in their room, we can either adjust the thermostat in their room, or we can call down to maintenance and have them do it. If they're really, really cold, especially our little older adults, they're always cold. You can give them multiple blankets. You can give them a warm blanket from the blanket warmer. I know our hospital, we have volunteers that make Afghans and little shawls. You could give them a shawl. They can bring clothes from home. Sometimes they bring in their robes or their favorite jacket, things that keep them, or even their favorite blanket. We want to make sure that we are positioning them and turning them. If they are not moving themselves, we want to do that every 2 hours, right? Because we want to eliminate the risk of them getting any kind of skin impairment. We want to keep them comfortable. That provides a good opportunity for you to have that therapeutic touch with the patient. Pull them up in bed, make sure that they're comfortable, putting their blankets on them, tucking their feet in. These are all things that help your patient feel comfortable. It's also a good opportunity when you're repositioning them to do them range of motion exercises with them. So moving their arms, extending their legs, moving their feet, their wrists. Again, you can always do a back massage, comb their hair. That makes them feel good about themselves. especially when you're sick and you don't feel good. The last thing that you really think about is your hair. So you can help offer to comb their hair. You can help offer to set them up. And then monitor that water temperature, because if they have any kind of impairment, they might not be able to tell the degree of the water temperature and they could burn their skin. So I will share this cute little story. So yesterday and Sunday, I worked on the same unit and I was taking care of this little man who was like 84 years old, and he was abused by his son, physically, mentally, neglect, the whole 9 yards. It was so bad that the state actually took this man away from his son. His son's not allowed to come around him. And they're petitioning to get full custody of him, and then they can place him somewhere. Well, they don't have full custody yet, so he has to stay in our hospital. He's been there almost 3 months. And he was so sweet, only oriented to like himself and his date of birth. He really didn't know what month it was, but he was as sweet as anything. And he had all this facial hair, like he hadn't been shaved in a long time. And when I went in yesterday, his hair was sticking up everywhere, and he had like all this thick, kind of looked like cradle cap. It was like just a lot of thick dandruff on his head. And I had time in the afternoon, so I wet his head and I took like a little thin black comb and I went through his head and kind of got all that disgusting stuff off of his head. And then I showed him a picture of himself, and he was like, look at that handsome guy. Look at that handsome guy. It was almost like he was a little kid. And then he started pointing to his face and said, can you shave this? So I went down to the gift shop and I bought like a little, because we don't have them on the unit, I bought a little thing of shaving cream. Long story short, I shaved his whole face, and he literally watched himself in the mirror that he had at his bedside table the whole time. And he kept on saying stuff like, look at that guy. He's handsome. Am I handsome? It was so cute. But just do those things for your patients. They make a world of difference with them, and it also makes you feel good. Like, to me, that is what nursing is. And I know myself that I never have the adequate time to really spend with a patient, because you're always caught up in these task-driven things like passing meds and doing this and checking that. And so it was nice for him, and it was nice for me as the nurse, because I really felt like I did something that made a difference. And you don't always get that in nursing, unfortunately. So, all right, the safe zone. So we want to make sure that we are establishing safe environments for our patients. If they have visual loss or hearing loss, we want to make sure that we put signs in the room and on the door. So when anybody comes, they know that this patient is blind, so that you have to, and then you would put on there on the door that the patient is legally blind, and then you would put what we want the outside people to do before they come in. So please knock before you go in. Please don't talk loudly. Please introduce yourself before you walk in the room. That lets other people know this patient is blind. We don't want you to scare them. If they have hearing loss, we want to make sure that we are putting into place everything that they need so that we can communicate with them. So if they need someone to do sign language, if they need their hearing aids, we want to make sure that they have things like that. If they have issues with smelling, we want to make sure all those things that we said before, that we remove those smelly things from the room, and then reduce tactile sensation. So patients who have diabetes that don't have feeling in their feet and their hands, we want to make sure that if they have issues with their hands, that we set them up. Can they feed themselves? If they can't cut their food up, maybe we need to cut their food up and open up all their lids and open up their milk, put their straws in. We want to make sure that their bed alarms are on, because if they go to get up and we're not there and they can't feel their feet, they could fall. So we just want to make sure that we are keeping our patients safe. And this is just a picture of a nurse that is working with a blind lady, leading her down the hallway. All right, so glaucoma. This is one of our exemplars. Glaucoma is a disturbance of the functional or the structural integrity of the optic nerve in our eye, with decreased fluid drainage in the eye or increased fluid secretions that anterior chamber becomes very congested with fluid or intraocular pressure, and it begins to rise. Normal intraocular pressure is between 10 and 21. Optic nerve damage can occur as the result of that increased intraocular pressure and visual defects. All right, so open angle glaucoma is the most common form. This is where the aqueous humor outflow is decreased because there are blockages in the eye's drainage system. As that intraocular pressure begins to rise, it's going to cause edema on the cornea. It's going to cause atrophy in those nerve fibers that are in the peripheral areas of that retina. And then over a period of time, it's going to cause degeneration of that optic nerve. So your patients with glaucoma are going to report headaches. They might have mild eye pain, may or may not. They're going to report a loss of peripheral vision. So that's your vision on the side. Decreased accommodation. Some might report that when they look at lights that they see a halo around the light. And then they're going to present with that elevated intraocular pressure. It's usually going to be greater than 21. We usually see it between 22 and 32. Then we have acute angle closure. So this is very sudden onset, and if it happens, it's going to require immediate treatment. What happens is the angle between the iris and the sclera, for some reason, it just suddenly closes. When that happens, it causes an increase in that intraocular pressure. Like I said, very rapid onset. It's usually that intraocular pressure is usually going to be 30 or higher. Patients can report decreased or blurred vision. They might see colored halos around certain lights. Their pupils will be non-reactive to light. They might report severe pain, even nausea, and they might have photophobia. Risk factors. So this can happen as we age. It could be caused by an infection in the body. If there's a tumor somewhere, this is prevalent in patients who have diabetes. Diabetes causes everything. It could just be a genetic predisposition. So someone else in your family had it, it's hereditary. We see this with hypertension, so uncontrolled hypertension. So diabetes can cause hypertension. Hypertension can cause glaucoma, any kind of eye trauma. So diagnostic findings, we're going to want to go to the eye doctor. They do these findings. You're going to want to, they will look at your optic disc. They're going to want to visualize that to see the stability. They're going to do an inspection of the anterior chamber of the eye. You're going to have a tonometry test. This is going to measure that pressure in your eye. And then patients that have this, they will have an elevated intraocular pressure. And then they're going to do a visual field exam because they are reporting that loss of peripheral vision. So how do we treat glaucoma? So clients with open angle glaucoma use topical beta blockers. One of the most prevalent common ones that we see is timolol or Timponic. There is no cure, but the disease symptoms can be controlled and we can prevent further damage of that optic nerve. So if the medication that we're using is working, that intraocular pressure when it's tested is going to be controlled, and we want it to be around 15. So these patients obviously are going to be getting eye drops. They're going to be taking them several times a day, sometimes 3 times a day, sometimes twice a day. It just depends. So when you are giving your eye drops to your patient, it's always good just to teach them to put their head back slightly. You can pull down on their eye and instill it at the bottom. Make sure that your patients have a tissue because some of it will come out of their eye. That way they can blot their eye. You can pull it down and just put it in the corner. I always ask my patients, do they want me to do it or do they like to do it themselves, especially if, they're alert and oriented and they seem independent with their care. Some patients are very particular about their eye drops and they want to do them themselves. Other people don't care, they'll let you do it. So those beta blockers are the first line drug therapy that we use to treat this. And how it works is it decreases that intraocular pressure by reducing that aqueous humor production that we talked about. All right, so we can also use prostaglandins such as latanoprost or bimatoprost that increase the outflow of the fluid in the eye, and they help reduce that intraocular pressure. We can use miotics, which is Myostat or Pilocar. Those are the two most common medications. What this does is it constricts the pupil and it allows for improved circulation and outflow of that aqueous humor. Sometimes patients can get IV mannitol, which is an osmotic diuretic. So they use this in emergency treatment for that primary angle closure glaucoma because it's going to work very quickly to help decrease that intraocular pressure. Then there's surgical management. So you could have what's called a laser trabecularplasty. You could use, they could do an aqueous shunt surgery. That aqueous shunt is going to go in there and help drain out all that fluid. It improves the flow of the aqueous humor by creating a channel out of that anterior eye chamber of the eye. All right, sometimes we use something called mydriatics, which is atropine. These are drugs that dilate the pupil. We don't want to use this I said that the wrong way. Mydriatics is something that we don't want to use because it helps dilate the pupil. That's not something that we want to do with glaucoma. In case it would ever come up onto your floor for some reason or the doctor would order it, you would just want to know that we would not want to give that. You would want to give analgesics to your patients that have the acute angle closing glaucoma. Usually we keep them on bed rest until it has resolved or that pressure starts to come down. And if they're reporting pain, that's when we give them analgesics. We want to make sure that we are preventing constipation and helping these patients have regular bowel movements. If they're constipated and they have to strain, that is going to raise the intraocular pressure of the eye, and we don't want to do that. We also want to avoid any heavy lifting or any emotional upsets, especially crying, because both of those things increase the IOP. And then we want to avoid activities that increase that IOP, such as bending at the waist, sneezing. Kind of hard to avoid a sneeze. You can try, but if it's going to happen, it's going to happen. Coughing, straining, and head hyperflexion. So we're going to want to, again, like we just said, limit those activities that strain the eye. Keep an extra supply of prescribed drugs on hand to remember when to take with you if you're going on vacations, if you're going somewhere for a holiday, or just in case you spill or lose one. Seek medical attention right away if you have immediate acute pain or any type of visual disturbance occurs. You want to tell all physicians that you go to that you do have this disorder and the treatment that you are currently adhering to. You also want to carry identification stating that you have glaucoma in case there's an illness or an injury and you cannot, you won't be able to tell that. Maybe you're unconscious because certain medications that they give and certain procedures can interfere with glaucoma and make it worse. And then you want to adhere to all your appointments and make sure that you're taking your medications and following up for your appointments like you should be to make sure that we're managing the disease. All right, so cataracts. So this is what vision looks like from a healthy lens. This is what a patient sees when they have cataracts. So cataracts are an opacity in the lens of the eye that ultimately impairs their vision. What happens is the lens becomes less flexible and it also becomes thicker. So it loses some of its transparency, which causes that cloudy vision. There's a high incidence of cataracts in diabetes. It's also genetic if there's a family history. We see this in patients that have had a prolonged exposure to ultraviolet light. So patients that sit in the sun all the time, or they go in tanning beds, if they've had radiation to the head, or if they've been subjected to radiation in their job or their environment. And then we also see this with patients who take corticosteroids. So what was an illness that we talked about the last class that we had that we would see patients that took a lot of corticosteroids?
Asthma.
Asthma, very good. So you might see a very high occurrence in patients that have asthma developing cataracts because they're on that steroid all the time. All right, so what are the signs and symptoms that these patients will report? They may report seeing a halo around lights. They might say that they're having difficulty reading things. They might report changes in their color vision. They might report that their colors are not as bright, that they appear faded or yellow. They're going to report poor night vision. Glaring objects in bright light cause blurred visions. So driving on beltways and two-lane streets where those headlights are coming right at them will cause them to almost feel like they're blind and they can't see. They could have double vision in one eye. They could report just blurry vision. And then sometimes, so this is an eye right here, a normal eye on the left, and this is what it looks like with a cataract. So what are some diagnostic findings that we would do? We might want to do a Snellen chart. When they go to the optometrist, they're going to do what they call a slit lamp examination, which is where they use that bright light to go in and look at the eye. That tonometry test, which throws that pressure, that air in there to measure the pressure in the eye. So surgical management is how we treat cataracts. You can do intracapsular or extracapsular extraction. And then you can do an intraocular lens implant. So what happens is they go in, they put you under like kind of like a twilight anesthesia. You really don't remember it. A small incision is made into the eye. They remove the lens. They break up the lens using sound waves. Once it's broken up, they remove it. The posterior capsule is then retained, and then they use a replacement or an intraocular lens to be inserted in its place. So post-op vision is usually restored. They might need corrective glasses, or they can use contacts. It's usually very successful. Whoops. So nursing management, some things that we would want to teach our patients. So their best vision is not going to be expected right away. It usually takes about 4 to 6 weeks following the surgery. You want to wear sunglasses while you're outside or in brightly lit areas. You want to report any signs of infection, such as yellow or green discharge. It could cause retinal detachment. I mean, it could be a sign of retinal detachment if you have pink eye, any redness, any kind of drainage, stuff like that. If you see any floaters in your vision, little black dots that you see that they just actually look like they're floating in your eye. If you start to see any flashing lights or an increase in redness in your eye, you would want to report that to the doctor. You should not be engaging in strenuous activity or any heavy lifting. They say usually between 1 and 3 weeks. You should not bend or stoop or do any other exercise that can potentially increase that intraocular pressure, because you want everything to stay calm until everything heals. Don't immerse the eyes in water. You can tell your patients that if they want to clean their face, that they can use a clean, damp cloth. Not to engage in any activity that could cause dust or particles to get lodged in the eye. So maybe sanding, if you have a workshop, maybe some older gentlemen like to sand, furniture and stuff like that. That probably would not be a good idea. And then you want to encourage your patients to eat foods that are high in vitamin C, A, and E, and beta carotene, which all support good vision. Oops. All right, so macular degeneration. So
before we move on, the vitamins say C and E. Do you want, you said C, A, and E. Is it just C and E?
C, E, A, yep. A should be in there too. All right, so macular degeneration. So this is what a healthy retina looks like. If we're looking from the side of the eye, and this is how we see our vision. This is normal vision. So with patients that suffer from wet macular degeneration, they have like this black spot right there in the retina, and then this is how their vision looks. It's what we call a central vision loss. And then if the patients have a dry macular degeneration, then they have like these little spots. And that's exactly what they see when they look out, is just these little black spots everywhere. So macular degeneration is a breakdown of or damage to the macula. This is the point of the retina where the light rays come in and they converge. This accounts for most of our acute visual perception. It causes a central loss of vision that affects the macula of the eye. We see a high incidence of this in age. So it is related to patients 50 years of age and older. It is the highest risk to Caucasians, patients who smoke cigarettes, patients that have hypertension. It can be hereditary, so there's a family history. And then we see these in patients who have a diet that is lacking carotene and vitamin E. So some of the signs and symptoms that they will report is dry. If they have dry macular degeneration, they're going to report blurred vision, central vision loss, and difficulty in a very low light environment. Things are going to seem worse. And then with wet macular degeneration, their vision is going to be distorted and their central vision is going to be affected. So how do we manage macular degeneration? So we use angiogenesis inhibitors. They can also have laser photocoagulation, photodynamic therapy. They can do intravitreal injections in the eye. There's something called a macular translocation. These are all in your book if you want to read about them. We can manage their diet. So really incorporating those fruits and vegetables and foods into your diets that are high in vitamin C and E. So your spinach and your collard greens are a good source of those vitamins. And then different fatty acids.
Miss Debbie.
Yes.
Yeah, please. When you talk about the macular degeneration, you said it is difficulty in low light environment, central light, loss of vision, and what else? Well, three things.
Blurred vision, central vision loss.
Okay, I got it. Thank you.
Yeah. Okay, so for nursing management, we want to help expand that visual field. So the patient should be taught to turn their head from side to side when walking because they need to see outside of that central vision area. This effort can help assist in improving the vision field, and it's also going to work to decrease the risk of injury when they're walking. And it helps to maximize the partial sight that they do have. So some of the nursing diagnosis that we would associate with this disorder is ineffective coping related to visual loss. So you could see how upsetting it would be for a patient that has this and how hard it would be for them. You might have compromised family coping related to deteriorating vision of a family member. Hopelessness, that's understandable, related to deteriorating vision while trying to maintain a lifestyle. Social isolation from an inability to drive because of recent visual changes. Self-neglect related to a change in vision. Risk for falls, right? Risk factor, visual difficulties, and then a risk for powerlessness because of their deteriorating vision. So a lot of nursing diagnoses go along with this. All right, and that is it for sensory alterations. Do you guys want to take like a 5-minute break before we start elimination, or you just want to keep going?
Yes,
Can
please.
we do a little quiz that go with it before we move on?
We don't have a quiz with this one.
I have a question. Which exam is this for? Is this for exam 3 or exam 4?
Hold on a second. Let me stop recording. Started. All right, so this is elimination. So we're going to talk about urinary elimination first. So the objectives are, we're going to describe the physiological, the physiologically, I cannot talk this morning, whatever. We are going to describe urinary. Oh my God, I think I broke. I mean, I can't even pronounce words. Describe the physiology of urinary elimination. Identify variables that influence urination. Assess urinary elimination using appropriate interview questions and physical assessment skills. Develop nursing diagnoses that correctly identify urinary problems. Demonstrate how to promote normal urination. Facilitate the use of the toilet, the bedpan, the urinal, and the commode. Perform catheterizations and assist with urinary diversions. And describe nursing interventions that can prevent the development of urinary tract infections. So this is a little review from anatomy and physiology.
Could you change the slide?
Oh God, yes. I don't know what my problem, you guys could do so much better than me. I don't know what my problem is. I'm sorry. It's hard because I'm going between two screens. All right, elimination from the urinary tract helps our body get rid of all the waste products and the materials that exceed what we need in our bodies. Urinary elimination is a precise system of filtration, reabsorption, and excretion. All these processes work together to help maintain that fluid and electrolyte balance that we have in our body, while filtering and excreting those water-soluble wastes. The primary organs of the urinary elimination system are the kidneys, with nephrons that perform most of the functions of the filtration and the elimination. Most adults produce 1,500 to 2,000 mLs of urine a day. The kidneys are located on either side of the vertebral column. They're located behind the peritoneum in that upper abdominal cavity. About once every 30 minutes, the body's total volume passes through the kidneys for waste removal. The kidneys filter and excrete blood constituents that are not needed. So whatever we don't need, the body filters out, and that's what we get rid of. And the kidneys know when to keep what we need. So if it's something that we need, they retain it. Urine is then that waste product that is excreted by the kidneys, and that urine contains organic, inorganic, and liquid wastes. And then the ureters, those are the hollow tubes that extend from our kidneys to the bladder, and they drain our urine. In males, they measure approximately 24 centimeters. In females, they measure approximately 4 centimeters. So that last part that I just said, so in men, they're much longer. Their ureters are 24 centimeters. In females, in relationship to our bladder, it's only 4 centimeters. So what do you think, based upon the differences in length of the ureters, what do you think women are at risk for developing?
UTIs.
Yes, very good, because everything is in such a small relation to the kidneys and the bladder. So it's very, very easy for that infection agents to just go up into those, into the ureters, into the bladder, spread up to the kidneys. That's why we're so at risk for developing UTIs. So this is, oops. This is in your book. This just shows you all the parts of the kidney, the renal vein and the arteries, the capillaries, the arterioles, the medulla, there's the ureter, all that good stuff. You can look in your book. So the term parenchyma refers to the functional parts of the human kidney, including the elements of the organ that create urine. The primary structural component of the renal parenchyma are the nephrons. The nephron is the smallest and basic structural and functional unit of the kidney. They are microscopic in size. There are about 1 million nephrons in each kidney. Each nephron consists of a glomerulus, an afferent and efferent arteriole, the Bowman capsule, a loop of Henle, various capillaries, and tubules. Nephrons remove the end products of metabolism, such as urea, creatinine, and uric acid from the blood plasma, and they help to form urine. The nephrons maintain and regulate fluid balance through the mechanism of selective reabsorption, that it picks what it wants to reabsorb based upon what our body needs, and it also secretes what it needs. So whatever water isn't needed, whatever electrolytes aren't needed, and other substances that we don't need. So this just shows you the glomerulus, that Bowman's capsule, the proximal tubule, and the distal tubule are all located in the cortex of the kidney, which is over here to the left. And then the loop of Henle and the collecting tubules are located in the medulla. So this should all be making a little bit of sense coming back from anatomy and physiology. So the urethra vesicle unit. So together, the bladder, the urethra, and the pelvic floor muscles form what we call the urethra vesicle unit. Our pelvic floor muscles work and they help to form a sling, which helps support our bladder, keeps it from falling. It gives support to the urethra, the rectum, and then also various reproductive organs. The urinary bladder is a hollow muscular organ. The shape of the organ and the size depends on the client's age and the amount of urine usually contained. Everybody's bladder can hold different amounts. Usually it holds about 300 to 500 mLs. And then your urethra, which is a hollow tube, which begins at the neck of the bladder and extends at the external meatus. And then again, we said the length for males was 24 centimeters and for females, 4 centimeters.
Professor Davis, Sarah's trying to get back in.
Okay. She's not there right now, but if she comes back, let me know. And then
Okay.
I'll get in. After filtration, occurs in the body, the urine passes through the ureters into the bladder, which is considered the storage reservoir for urine. Once an adequate amount of urine, usually between 150 to 200, it depends on each person, collects in the bladder, stretch receptors in the bladder wall send a signal to the brain to indicate that we have to urinate. The person then relaxes that internal and the external sphincter at the bottom of the bladder and the urethra, and then the urine passes from the bladder through the urethra, and then it exits the body. So the urinary bladder, like we said, is a smooth muscle sac that serves as a temporary reservoir for urine. It's composed of 3 layers of muscle tissue. There's the inner longitudinal layer, the middle circular layer, and then the outer longitudinal layer. These 3 layers all are called the detrusor muscle. At the base of the bladder, the middle circular layer of muscle tissue forms the internal or that involuntary sphincter, which guards the opening between the urinary bladder and the urethra. The urethra conveys urine from the bladder to the exterior of the body. And this is that example of the different layers of the bladder, that external sphincter, the internal sphincter, and then the detrusor muscles. You can see the different layers there. So the urethra's function is to transport urine from the bladder to the exterior of the body. The anatomy of the urethra is different in males and females. The male urethra functions in the excretory system and the reproductive system. In contrast, the female urethra, the male's is 5.5 to 6.25 in length. The female's is 1.5 to 2.5 inches in length. The external or voluntary sphincter is located in the middle of the urethra, and no portion of the female urethra is external to the body as in the male. All right, so factors that affect micturition. So there are developmental considerations to think about. So when we think about children and when they start to toilet train, they usually gain voluntary control of those urethral sphincters between 18 and 24 months of age. However, even though they have control of that sphincter, there's other factors that are required in order for them to be conscious about their bladder function. So usually between ages 2 and 3 is when everything is right at that age for them to be able to think about toilet training and start the process. So they need to be able to hold their urine for at least 2 hours. You want your toddler to be able to recognize that feeling of a bladder fullness and say, oh, okay, now it's time for me to go to the bathroom. And they need to be able to communicate that need. And then they need to be able to hold their urine until they're seated. So a lot of things have to come into play before toilet training can start. The effects of aging also affect our urination. As we get older, and this is important information, this is an important slide, there is a diminished ability of the kidneys to concentrate urine. Because we can't concentrate our urine, this results in nocturia. Nocturia is when you get up frequently throughout the night to go to the bathroom multiple times at night. We have decreased bladder muscle tone, which reduces the capacity of the bladder to hold urine. If we can't hold a lot of urine, we're going to have increased frequency of urination. We're going to have to go more often. We have decreased bladder contractility, which can lead to urine retention and stasis. So whenever we keep urine inside of our bladder, it's the perfect medium for a growth of infection. So our likelihood of developing a UTI skyrockets. If we have any type of neuromuscular problem, this can affect our frequency, urinary retention, and stasis. In men, the prostate enlarges after 40 years of age. When that happens, it can cause urinary frequency, hesitation, retention. It can be difficult to start a stream. They can even have incontinence, and they can also suffer from urinary tract infections. And then there's degenerative joint problems, and then alterations in thought processes, which can cause problems with urination. So if you have degenerative joint problems and you feel like you have to go to the bathroom, but then your mobility is impaired, you might not be able to get there in time. So you might have issues with incontinence. And the same thing with alterations in thought processes. If you can't, if you have any problems with your thoughts, or you're confused, or you have any type of dementia, then you're not going to be able to hold your urine, and you're not going to be able to be continent. So fluid and food intake. So when our body is functioning well, our kidneys maintain the proper fluid intake and output. It happens on an equal basis. What we take in, we put out. When our body's dehydrated, our kidneys reabsorb fluid. The urine that we produce is more concentrated, and it is decreased in the amount that we put out. With fluid overload, the opposite, the kidneys excrete a large quantity of dilute urine because we have so much of it. So it's dilute. If we don't have enough of it, it's concentrated. Alcohol also produces a diuretic effect. It inhibits the release of antidiuretic hormones, which increases our urine production. And then certain foods that we eat may affect the odor or the urine. So asparagus or onions can cause your urine to have a foul odor, or its color in beets. Beets sometimes can cause your urine to be a little pink. So if we went into our patient's room to empty their urinal or to measure their output, because we're doing strict I's and O's, and we saw that their urine was very, very concentrated, what would it look like if it was concentrated?
Dark.
Yes, it would be dark. What would be something that we could encourage our patients to do if they have concentrated urine?
Drink more water.
Yes, increase their fluid intake. So if they're not capable of taking in fluids on their own, what would we recommend as the nurse?
An IV.
Yep, IV fluids, you got it. So there are psychological variables. So our own individual, our family, or our socio-culture variables influence our voiding habits. Some people believe that voiding is very personal, it's very private, it should never be discussed. So asking for a bedpan or a urinal, or having someone, if you're a high fall risk, we can't leave our patients alone. This is hard for patients. They don't want you to stand over top of them. It can cause them to be anxious and embarrassed. So these are things we have to think about. Activity and muscle tone. So when patients are immobile for prolonged periods, this is going to decrease their bladder and their sphincter tone, which can result in poor urinary control and then urinary stasis. So they're going to be subject to increased risk of urinary tract infections. We know that the benefits of regular exercise, there are many, but it also increases our metabolism, and it produces optimal urine production and elimination. When patients have an indwelling urinary catheter, because they have that catheter and the urine's just coming out on its own, sometimes, if it's been a long time, they lose bladder tone, which causes the muscle not to be stretched by the bladder filling with urine. So then once we take that urinary catheter out, we see a problem with these patients being able to make urine on their own. Sometimes it takes them a while. With patients that have decreased muscle tone, such as when they give birth to children, there's certain muscle atrophy that happens, and then decreased estrogen levels, as seen with menopause, that also come into play with urinary issues. So there are certain renal or urologic problems that can affect how much urine we put out, and then the quality of urine that we put out. So diseases that are associated with renal problems include congenital urinary tract abnormalities, patients that have polycystic kidney disease, frequent urinary tract infections, kidney stones, hypertension, diabetes. I think diabetes contributes to just about everything. Patients that have gout, which is an increase in your uric acid in your system. Patients that have glomerulonephritis and certain connective tissue disorders all can have issues with urination. So renal failure is a condition in which our kidneys fail to remove all those waste products from the blood, and they're unable at that point to regulate our electrolytes, our fluids, and our pH balance. So there's a couple different kinds of renal failure. There's acute kidney injury, which is, it's called acute because it happens very suddenly. It's a decline in kidney function, but it's usually temporary and reversible. And it may be caused by conditions such as severe dehydration, anaphylactic shock, if a patient is sepsis, or if they have some type of ureteral obstruction. So during the summertime, as the weather gets nice and people start going out on their boats, they start riding their bikes, they're doing activities outside, you will, if you work in a hospital as a nurse, you'll see a lot of patients that have acute kidney injuries because they're out in this hot weather and they forget to drink. So it is very common. Then we have chronic kidney disease, also known as CKD, which is a slow loss of kidney function that happens over a period of months or years. And it causes irreparable damage to the kidneys. You cannot repair this. You cannot reverse chronic kidney disease. You see chronic kidney disease with patients that have diabetes, hypertension, and glomerulonephritis. So you will notice these patterns with diabetes and all these diseases. So if you have a patient that has chronic kidney disease, it's probably because they have diabetes. If you have a patient that has diabetes, they probably have, if it's been uncontrolled for a long period of time, they have hypertension and they have chronic kidney disease. And some of them end up on dialysis, and some of them end up not making any urine at all. So it is a progressive disease. It will eventually lead to the end stage renal disease or complete kidney failure. In end stage renal disease, the kidneys are unable to adequately excrete metabolic waste and regulate those fluid and electrolyte balance. We also know that medications have a big effect on our urine production or elimination. The ones that we really worry about are ones that are nephrotoxic. So these are medicines that can cause damage to the kidneys. We also want to know about medications that cause our patients' urine to change color, because if we're giving them a medication that's going to change their urine, we want to be able to educate them about it so that they're not alarmed. So there are certain types of anticoagulants that cause, if you're on an anticoagulant, your blood is thin, you might see blood in your urine. So you could have pink or red color in your urine. And this is an important slide. You guys want to know this. Certain diuretics can cause our yellow urine to be very pale. Why do you guys think that if a patient is on a diabetic, that it would, on a diuretic, that it would cause their urine to be pale?
Water.
Yes, it's increasing the water, and it's increasing your urine output. So that urine is not going to be concentrated, it's going to be dilute, okay?
Okay, can you let Sarah back in?
Yep, I just did.
Okay.
There's an antidepressant called amitriptyline, or B-complex vitamins sometimes cause your urine to be green or blue-green in color. And then levodopa. So what do we give levodopa to? What type of patients do we give levodopa to?
Parkinson's.
Yes. So this medication or certain injectable iron compounds can cause brown or black urine. So these are things that, as the nurse, you would want to watch out for, and you would want to expect to see these in your patients, okay?
I have a question. What about the one that turns your urine like orangey?
Yes, didn't we talk about that one? Hold on. Peridium?
Pyridium, yeah, that's okay.
Yes, and I think I skipped over it. I'm sorry. I skipped right to that antidepressant, but yes, peridium. You can get that over the counter or your doctor can prescribe it if you have a urinary tract infection. And what it does is it takes away all those feelings of if you have burning, pain, cramping, you have like that pulling sensation when you feel like you're trying to go, it decreases those side effects. It's like a miracle pill. Actually, if you have a urinary tract infection and it's bad, that pill really helps, but it does turn your urine orange or like an orangish red color. All right, so the nursing process. So when we are assessing our patient about voiding patterns, their habits, and their past history of problems, we want to know certain things about them. Especially if they have issues with urinating and their incontinence, and we want to, some patients will put like on a bladder retraining program. And this is important. You're going to want to know about bladder retraining programs. In order for us to put them on a program where we can retrain their bladder or put them in patterns where we have them void on a consistent measure so they don't suffer from incontinence, we need to know when our patients are incontinent. So we want to know if it happens, when does it happen? Does it happen after they drink, about an hour after they drink? Is it worse when they first get up in the morning? Is it worse in the middle of the night when they're trying to get to the restroom and they have trouble ambulating to the bathroom? When is the client incontinent? That's what you really want to know. So you want to make sure that you're asking those questions so that you can get that information. So some of the questions that we can ask about voiding patterns and habits is, how do you urinate during the day? So do you use a brief? Some people use a brief. Do you use a bedside commode at home because your bathroom is on the second floor and by the time you climb all the steps, you will have urinated on yourself? So maybe you have a urinary bedside commode in your living room, which is good for you. Do you awake at night to empty your bladder? If you do, how many times are you getting up at night? We want to know what their urine looks like. So do you have any problems with burning or pain when you go? What color is your urine normally? Describe it. Is it cloudy? Is it clear? Does it have an odor? Do you see any sediment or any chunks of pus in there? Have you had any noticeable changes in your usual urinary pattern? So do you go more frequently? Is the amount that you're putting out increased? Is your stream diminished or is it stronger than normal? Do you have any difficulty starting a stream, or is it uncomfortable when you're going? Do you have pain? Do you have burning? We want to find out, do they ever leak urine? So do you ever dribble on the way to the bathroom, or do you dribble or release a lot of urine when you sneeze or cough, which could be a sign of stress incontinence? Do you ever notice that your undergarments are wet or damp? And then you want to ask them any problems that they're having currently. So we want to look at problems they're having currently, problems that they've had in the past. And then if they've had problems in the past, what they've done to resolve them, or what are they doing currently to manage any type of condition. And then we want to know if they use any type of absorbent pad to help protect their clothes. Okay. Terms that we use to describe urinary issues. So these are what we say using our nursing words. When you're giving report, if any of your patient has these issues, this is how you're going to want to describe them. So anuria is urine output that is less than 50 mLs in a 24-hour period, okay? Dysuria is painful or difficulty when you're trying to urinate. Frequency, obviously, is an increased incidence of voiding. Glycosuria is the presence of glucose in your urine. Nocturia is when we get up in the middle of the night to urinate. Oliguria is a 24-hour urine output of urine. So like when you're getting diuresed, Polyuria is excessive output of urine. Again, when you're diuresing, it's pretty common. Proteinuria is when we have protein spilling into our urine. Pyuria is pus in the urine. Urgency is a very strong desire to void. And then urinary incontinence, obviously, is involuntary loss of urine. So when you're doing that focused assessment, we're going to talk about all the things that we said. We want to talk about the duration of their issues, the severity, any precipitating factors. You want to note their perception to the problem. So how bad do they perceive it? How bad does it affect their life? You know, if they talk about incontinence and then they say that they really don't have a lot of friends and they don't go out anywhere, you know, then they might perceive their problem as being very bad, and it affects their social interaction with family members and friends. And then you want to check on the adequacy of the patient's self-care behavior. So are they even able to take care of themselves? Are they properly cleaning themselves so they don't get UTIs? Are they, if they wear pads, are they able to get up and go to the bathroom? Do they have impaired mobility so that they're soiling themselves all the time and that they're at an increased risk for skin infection? So you always want to check about those self-care behaviors. So goals for eliminating urinary problems. So we want to maintain or restore normal voiding patterns. We want to regain normal urine output. And there's going to be various different ways that we can do this. So if a person's sick and they're not taking in a lot of fluid and they're dehydrated, then we will give them fluids and encourage oral intake to help regain that normal urine output. We want to prevent infection and skin breakdown. So these are with our patients who are incontinent. We want to make sure that they are able to toilet themselves at home, that they are changing their pads or their briefs, because we don't want that fluid, that urine sitting up against their skin, causing skin breakdown, causing infections. We want to correct our fluid and electrolyte imbalances. And then we want to help them with their self-esteem, especially if they're having incontinence issues, they might not feel too good about themselves. We want to make sure that they can perform toilet activities independently with or without assistive devices. And then if they require assistive devices, if the patient has to ambulate with a walker and their toilet is on the second floor of the home, then we want to maybe advocate and make sure that they can have a bedside commode delivered to the house so that they can independently get to the bathroom, because maybe they are continent of urine, but by the time they get up the steps, or if they have to walk a great distance, then they can't hold it. So then they start urinating on themselves. So we want to promote them to be as independent as they can be. We want to contain urine with the appropriate device. So we want to use an ostomy. If they have an ostomy, we want to make sure they have a bag attached to collect it. We want to make sure we're using an absorbent product. So those briefs or those absorbent pads that we're changing frequently. If need be, maybe they'll have a catheter. And then we always want to make sure we're doing education with that family member and the patient with regards to any discharge planning and anticipating any needs that they're going to require when they go home. So when we are doing this physical assessment of our patient, actually, hold on a second. I had a picture here that I wanted you guys to see. Okay, so when you're assessing your patients, you want to check for what we call costovertebral tenderness, or we also call it flank pain. So patients that have kidney infections will have pain in this area. This is the costovertebral angle. So you would also want to, we talk about palpating for tenderness and percussing. As nurses, we don't percuss. That's usually done by NPs, nurse practitioners, physician assistants, the doctors, things like that. We can look at the urinary bladder. We want to examine that. We can palpate it. to feel it. So normally it's located below the symphysis pubis and you cannot palpitate it. If it is swollen or they're retaining fluid, their whole abdomen is going to be distended and you will be able to visually palpate that the bladder. We can use a bedside scanner. We just call it a bladder scanner, and that actually uses little sound waves with some of that gel to visualize the bladder, and it'll give you a pretty precise, accurate measurement of the urine that is in the bladder, because it can be an indication that we would have to straight cath our patient if they have a certain amount in there. We would want to look at the urethral meatus. We want to look for any signs of infection, if there's any discharge coming out that shouldn't be there or any abnormal odor. We want to look at their skin around where they urinate from. We want to assess for color, skin breakdown, turgor. Are they always soiled when we go in? We want to make sure we're cleaning those pads, putting moisture barrier around the area if we can. If they're frequently urinating, we can do like an external catheter to try and keep that urine off of their skin. So it's not like an internal catheter. It's not as invasive. It's just like we call it a prima fit, and it's shaped like a kind of like a large tampon, and then it's connected to a suction system on the wall. And as they pee, it automatically sucks it away from their skin and puts it into a suction container. So sometimes if our patient is incontinent, we will actually do that for strict isonos, because it's really hard to do strict isonos when you have a patient that's incontinent, because you keep going in each time and they have these absorbent pads that are soiled, but we're not really being able to get an accurate measurement of how much that is. So I will put these external catheters on patients where I need strict isonos and they're incontinent. And I'll also do it if I think they have a urinary tract infection, because then I'll be able to see the color of their urine. You can see the color on an absorbent pad, but you can't tell if it's clear. And you would want to know if it has any sediment or pus in it. So that's another way to visualize your urine. When you're looking at your urine and you document it, you're always going to assess and document the color. So is it yellow? Is it amber? Is it brown? Is it red? You want to note if there's any odor to it. Is it foul, or is it like a sweet smell? Sometimes it'll smell just have like a sweet scent to it if there's high glucose in the urine. You want to look at the clarity. So is there sediment? Is there pus? Is there blood? Is there blood clots? Is there maybe vaginal discharge? Is there protein or glucose in it? So we would want to test for, we could send off different labs to look at protein to see if they're spilling any protein, glucose, or ketones or bacteria into the urine. There's a chart in your book, chart 37.1, that looks at different characteristics of urine. You can look at that, it's pretty helpful. All right, so what other type of diagnostics can we use? So we're gonna do that history, we're gonna do the physical examination, then we can do diagnostic tests. So we can do what we call a KUB, which is an x-ray of the kidney, ureter, and bladders. So we just call it a KUB. We can do a retinal arteriography, which is a special x-ray of the blood vessels that are located inside the kidneys. What it does is it injects a dye through your veins, and it travels through the kidneys, and it helps visualize all those detailed structures of the kidneys. We can always use an ultrasound machine to look at the kidneys. Your CTs, your MRIs are going to be more detailed. I'm going to show you more of those visual detailed structures of the kidneys. We could do a cystoscopy, which is a procedure where a doctor uses a light to look inside the bladder and the urethra. So it's a tube that connects to the bladder to the outside of the body, and it's done with what we call a cystoscope. It has a light on it and a lens and a small video camera on the end, and then it's inserted to the urethra, so it can check for different issues. When we talk about subjective data, we would want to get the client's description of their urinary patterns. So how are they describing it? Are they saying they have burning and pain? Are they saying they have bright red urine? Do they say that their urine is cloudy? Make sure you're doing that specific questioning, right? You want to know when they last voided. How many times a day do they normally void? What's normal for them and what's happening now? Has anything changed? How much do they put out each time they go? Is it different now than compared to what it used to be, or is it pretty much the same? And then anytime you wake up for at night to go to the bathroom, you just want to be sensitive to clients, because some patients are very private about these issues, and they're also embarrassed, especially if they are having issues with incontinence, especially younger people. So once women go through menopause, it is very common that they have issues because they lose that estrogen, and then they have a harder time holding on to their bladder, holding their bladder. So then they start having stress incontinence, and then they just start having incontinence in general. So they have to wear pads more often. They feel like they smell. It's so you just have to be conscious of the population of people that you're dealing with and understand that it can be very embarrassing for some patients. So then we want to look at that objective data. So that objective data is the data that we as the nurse see. So we're going to be assessing that urine. What does it look like? What's the color? What's the clarity? Does it smell? Are there blood clots in it? Are there pus? We're going to be doing strict I's and O's. So if it's a patient that's independent and they go to the bathroom on their own, if it's a male, you can give them a urinal. If it is a female, you can give them, we put like a hat in the toilet that has measurements inside of it. We put that in the toilet and tell them that every time they go to the bathroom to call us, and that we will come and measure it, so that way we can document what's going in and what's coming out. If they're not having good urine output and they're not urinating at all, we might want to do a bladder ultrasound to see if they're retaining. If they're retaining, we might have to do a straight cath, where we just go in one time and grab that urine out. So we're going to be doing that physical assessment. We talked about that. Inspection, palpation. We're not doing the percussion, palpation rather. You want to do those diagnostic tests and procedures that we talked about. You might have to do certain urine specimens. We're going to talk about them. We might just have certain random specimens, which is just aseptic technique, where they just go in and they pee in the cup. Sometimes we do midstream. So what happens is they clean really, really well, and then they pee a little bit out, like 30 to 50 cc's or mLs, and then they stop, and then they put the cup under them, and then they start peeing. Sometimes we look at 24-hour specimens, where we collect their urine for 24 hours. We throw out the very first one of the morning, and then we keep the container on ice. We have to keep replenishing the ice, and then we hold that urine. We keep adding it for 24 hours. And then when the 24 hours is up, then we send it to the lab. We can take specimens from a catheter. So if we take specimens from a catheter, it can, if it's the very first time that you put the catheter in and it goes into the bag, you can take it from there. If it's a catheter that's been in for a while, you cannot take it right from the bag, because it's been sitting there and then it's growing bacteria. So it's going to give false information. You can also, there's another little piece to the foley at the top where you can clamp you could clamp the foley tube off by bending it in half, and then you hook your little syringe up to that side port that comes off. You'll see it in the lab when we talk about when we do Foleys, and then you can get the urine from there, because that's the urine that's actually just coming out. And then we can do blood tests, and then just regular urine tests, urinalysis. So this just talks about urinary retention, how it happens. So, here's your patient that's immobile. Maybe they had a hip replacement. Maybe they had a broken hip and they had to have their whole hip replaced. So they don't get on a bedpan very easily. It hurts. Or they're in an unnatural position for urination, especially our men. Men have a hard time urinating in a urinal from bed. It can be done, but a lot of patients struggle with it. So if they can't stand up, they're going to have a hard time. And And the same thing with women in bed. Sometimes it's just hard to go on a bedpan. So this is embarrassment. They don't want people to see them in that light. They don't want people to stand there while they're peeing. So it just starts this whole pathophysiology of decreased muscle tone, inability to relax the muscles, which causes urinary retention. Then the bladder becomes distended. The bladder causes pain. We have urinary incontinence and dribbling. So it's a kind of like a vicious circle. So this is just the assessment that that's subjective data and the objective data that you would look at. And then it also offers certain nursing diagnoses according to priority, and then some care plan implementation strategies, and then how you would evaluate. So this is good for you guys to read. I'll let you guys read that on your own. So when we want to look at different structures of the kidney. So we said we could do that KUB, which is going to look at the kidneys, the ureters, and the bladder. We can do a pyelography. So there's two. There's an intravenous pyelogram, which can be excretory or intravenous. The intravenous pyelogram is a radiographic examination of your kidney and the ureter. And what happens is they inject a contrast material intravenously, and it goes to all those little detailed places in the kidneys, and it can be used to diagnose renal disease and dysfunctions within the urinary tract. Then we have what's called a retrograde pyelogram, and this is a radiographic and endoscopic examination of the kidneys and the ureters. So what they do is they place a urethral catheter in up to the level of the renal pelvis as part of the endoscopic examination. Then they inject contrast material into the renal pelvis through the catheter, which highlights all those areas. And then they do different radiographic images so they can diagnose any problems. Let me see, I was trying to show you guys this video. Let me see if it'll work.
The flexible cystoscope is removed,
Can you
and the
guys?
guide wire is left in place.
Okay.
A dual lumen catheter is placed over the wire and inserted under fluoroscopic guidance into the ureter.
So now they're going to inject the contrast.
Contrast medium is injected through the dual lumen catheter in order to delineate the anatomy of the upper urinary tract.
And this is all done under sterile technique. And then they're visualizing everything they see on these two computers over here.
A second guide wire is inserted through the dual lumen catheter. The dual lumen catheter is removed. Note the different exit points of the two guide wires from the dual lumen catheter.
Okay. And let's see, I think there was another one too.
This unforgettable vacation memory.
Uh-oh, hold
It didn't
on.
actually
right, let's see.
We can't hear it.
Oops, hold on.
Evaluate your urinary system's functions and assess any abnormalities. It may also be used to diagnose blood in the urine or pain in your side or lower back. During an IVP exam, iodine-based contrast material is injected into a vein in your arm where it travels through the bloodstream and collects in your kidneys and urinary tract while X-ray images are taken. If you're scheduled for an IVP exam, there are several things you can do to prepare. First, tell your doctor about any recent illnesses or medical conditions, medications you're taking, and whether or not you have any allergies, especially to iodine-based contrast materials. Inform your doctor if there is any possibility you may be pregnant. You may be asked not to eat or drink anything and to take a mild laxative the evening before the exam. Leave any jewelry at home and wear loose clothing. You may be asked to wear a gown during the exam. You may have concerns about IVP. While an IVP exam does use radiation, the benefit of an accurate diagnosis far outweighs any risk. Plus, an IVP exam may provide enough information to allow your doctor to treat you with medication and avoid invasive surgical procedures. To learn more about intravenous pilogram, visit radiologyinfo.org. Thank you for your time.
All right. So then we can also, we talked about the retrograde. So we can do a cystogram, which uses a lighted instrument to visualize the bladder and the urethra. You can also, while you're in there, apply different treatments depending upon what they find, different antibiotic treatments, and you can also grab specimens during that procedure. We can do what's called a voiding cystorethrography, which is a rapid series of x-rays that they take while the patient is voiding. This is contraindicated in a UTI because with UTIs, you're not putting out enough urine for you to be able to do that. There's different urodynamic studies that we can use to evaluate the bladder. It can check to determine renal function. It can look to find out what a cause is of reduced urinary flow. So if you're going to the bathroom, but you're not putting out enough urine, and it can be used to figure out why you're suffering from urinary retention or incontinence. So we have a uroflowmeter, which measures the flow of your urine. We have the cystometography, which is the evaluation of the pressure and the volume relationship of your bladder muscles and the control of how your bladder empties. We use this to identify a cause of certain bladder dysfunction issues. So we talked about some of these already. So some of the laboratory tests that we can do. So we can do a urinalysis, which is a study of all the different urine components. So it looks at, it can look at characteristics of your urine. It can monitor certain treatments of urinary issues to see if they're working. It can diagnose certain renal conditions. One of the things you want to think about when you're doing a urinalysis is that they always want you to, you can only send a urinalysis that just has urine in it. So if your patient has diarrhea, you can't mix stool with it. If there's blood, you would want to make sure that if it's a female that has their period, maybe you would just want to call ahead to the lab or send a note that says, just so you know, the patient has her period, because it's going to show blood in the sample that you send. So what I like to do is if I have patients that have diarrhea, I put 2 hats in the toilet, one at the front where they can pee, and then one at the back, where if they have diarrhea or they have to have a bowel movement, one goes in there. And sometimes it works, sometimes it doesn't. And you also want to tell them not to put any toilet paper, they can wipe, but then they have to put it in the trash can or put it in the back of the toilet so that it doesn't go in the urine. We can do a urine culture and sensitivity. So after, this is not just the patient peeing in a cup, it's a little bit more detailed. So you want the patient to thoroughly cleanse that urethral meatus. And then you want your clients to catch the urine sample midstream. So that is where they're going to go in and they're going to clean really well. Then they're going to start to pee, let a little bit of pee out, and then in the toilet, and then they're going to, put their cup under there and pee in the cup. We do that 24-hour urine collection. It's looking for protein in the urine. Discard that first voiding, collect all the other for 24 hours. Make sure you keep it on ice in the room. Make sure you keep replacing the ice. And then when you're done, you label it and then you transport it to the specimen to the lab. Urine specific gravity, this is a test that's going to look at the concentration of all the different chemical particles in the urine. Then we can look at urine osmolality, which is the concentrations of all the particles in the fluid. So when we think about this, if you want to think about syrup, so syrup is very, very thick and it's sugary and it has a very higher osmolality than just a cup of water with just a tiny bit of sugar in it. So that's what we mean when we think about osmolality. The urine osmolality test does measure the amount of different compounds in your urine. Some of the compounds that we look at, we can look at chloride, we can look at glucose, we can look at potassium, sodium, and urea. And then we look at BUN, which is the blood urea nitrogen, and then our creatinine clearance. These are what we look to determine the measure of renal function. So when we measure our urine output, this is our strict I's and O's. We are going to ask the patient to void in a bedpan, a urinal, or a specimen container in the bed or the bathroom, because we want to be able to measure it accurately. You want to make sure you tell them if they wipe not to put it in the same container because the tissue will soak up some of the urine and it's not going to be accurate. You want to pour your urine into an appropriate measuring device. Some of the hats that go in the toilet, they're white, and then the inside of the bowl where the urine collects has different numbers on it, and you can measure that way, or you can pour it into a graduated cylinder. If you have a patient that's using a urinal, there's always numbers on the side, so it's easy to determine. You want to make sure that you're placing the container on a flat surface so that you can read it at eye level and make sure that it's accurate. You want to note the amount of urine voided and record their urine output in the computer, and then discard the urine unless the specimen is needed. So this is just a couple of the devices that we use in the hospital to collect and measure for urine. This is a urinal, a bedpan. This is a urinal. This is a fractured bedpan. So this bedpan here on the right, I use for all my teeny tiny little old ladies that have, or patients that have back issues, because you can see this big honking thing here. If it's a really teeny tiny lady or someone that has back issues, it's really, really uncomfortable. And then you can't really see from the position of this, but one end of this is lower than the other. You always just want to make sure you have the lower end towards the back and not vice versa, or it's going to really, really be uncomfortable. And then these are just some briefs. We have to remember when we're dealing with patients that do have these briefs that we call them briefs and not diapers. I've done it myself. I'm guilty of it. It's easy to say. And if it's a patient that's not really with it, they don't hear you or understand. But if it's a patient that is with it, it can be a little humiliating to them. And then this is that hat I was talking about that we put in the toilet. We call it a hat, and you can see in the middle it has all the numbers there for you to measure. This is a graduated cylinder, and this is just a specimen cup here. And then this is an example of a bedside commode. So nursing diagnoses, we can use impaired urinary elimination. We can use stress urinary incontinence, risk for urge urinary incontinence, risk for infection. If they have an infection or some kidney stones, pain might be a diagnosis. Impaired skin integrity, disturbed body image, especially with those patients that are incontinent, toileting self-care deficit, and deficient fluid volume. So our planned patient goals. We want to produce sufficient quality of urine so that we can maintain that fluid, electrolyte, and acid-base balance. We want to make sure that we can empty the bladder completely at regular intervals without discomfort. We want to provide care for urinary diversion and know when to notify a physician. So if the patient is not emptying their bladder like they should. If they've gone 8 hours and they haven't had any urine, that's a problem. That's when you would want to call the physician. And you might want to do a straight cath, or you might want to do a foley if it's going to be a continual issue. You want to develop a plan to modify factors that contribute to current or future urinary problems. So what is a way that we can advocate for our patients so that they don't develop any kind of urinary problems when they go home? What are some things we can think of? Sarah, what do you think?
You said avoiding problems with urinary?
Yeah, some things that we can think of that could cause them issues when they go home.
I mean, maybe for females, having them wipe like front to back.
Yes, very good. That's a good topic, because you would be surprised how many patients don't do that. And what are they at risk for when they don't wipe front to back?
UTIs.
Very good. Good job, Sarah, but I need your camera on because I can't see your face. Okay. All right. What are some other things that we can do? I'm going to pick somebody. Let's see. Sophie. What are some other things we can do? What are some things we can anticipate for when they go home? Some things we can advocate for. Sophie, can you hear me? I think you're muted. All right, Dina, what do you think?
Well, for nurses, you guys need to go to the restroom and stop holding I know it's practically impossible sometimes with all of the clients that you have, but not just for nurses. Sometimes you're a mom and you got to do a whole bunch of stuff and you got to feed your kids and you got to go, but they need your help first. So that, and also fluid intake, increase your fluid intake, make sure that you are adequately hydrated.
Yes, very good. And then when we're checking to see what their mobility is, thinking about how are they going to be able to ambulate at home if they use a walker? What's their living situation like? Do they have steps? Maybe giving that bedside commode. Do they have access to briefs and things that they can, because sometimes with patients that are retired or that are on a limited income, those things can be really expensive. So you can talk to social work and they can get them set up with programs that will deliver those to their house for free. So really utilizing all your resources and knowing when to advocate for your patient is very important. So we talked about promoting normal urination. So we want things that can promote normal voiding habits are promoting our fluid intake. So we should take in between 2,000 to 2,400 mLs per day. That's 8 to 10 8-ounce glasses a day. This ensures that our kidneys and all those urinary structures are very well flushed, and they're going to remove all those waste products and bacteria. We can strengthen our muscle tone, so we can use what's called pelvic floor muscle training. This can help to improve voluntary control of urination. It significantly reduces and eliminates problems with stress incontinence. So stress incontinence is involuntary loss of urine related to an increase that we see in our intra-abdominal area. It causes pressure. We can do strengthening perineal and abdominal muscle tone exercises that will help. One of the main things that we recommend is Kegel exercises. You can look in your book. Your book talks about how to do a Kegel exercise. If you've had kids, you probably do them. And then we can help assist with toileting, making sure that we are there to help our patients when they have to go to the bathroom. Try and get there as timely as possible. So, maintaining normal habits. We can set up a schedule. Some patients report urinating on demand, and there's no particular pattern. Others have different patterns that have developed over a number of years, and some become very anxious if they're interrupted. So you need to know what their normal pattern is. Just like we said with the bladder training, we need to know when they're incontinent so that we can try and fix the problem. So we need to know what their patterns are. Patients that need assistance to urinate may experience urgency. So we should, as nurses, try to support their urinating pattern as much as possible. We want to put them on a schedule. Make sure that you talk with your tech and they know that this is what you're trying to do for Mrs. Jones. Let's go in every 2 hours. She always has to pee right after she eats lunch, or whenever she eats a meal. So I'll go in an hour after breakfast, you go in an hour after lunch. Whoever has time can go in an hour after dinner. So getting that plan together, putting them on a schedule, knowing when they're going to be incontinent or when they have to go. Sometimes patients have an urge to void, which means that when they feel like they have to go, they really just have to go. There's no waiting. So if we delay that urination, this can cause difficulty in them actually being able to initiate a stream when they have to go. And it also causes urinary stasis. And we know that if we have urine that's just sitting in there in that warm, hot, dark environment, it's the perfect breeding ground for what?
Bacteria.
Right, so we can get a UTI, very good, which could lead to a bladder infection. All right, so when we're thinking about privacy, we want to help our patients go to the bathroom and keep their normal voiding patterns and positions necessary so that they can urinate, but we also need them to be safe. So all the time, patients will say, I don't want you to stand here and watch me, but they're a high fall risk. And the policy in my hospital is you cannot leave them if they're a high fall risk. So if they're completely alert and oriented, I will say, I'm going to stand right outside the door. And that's exactly what I do. I stand right outside the door and I do not leave. And then I will crack the door and say, Mrs. Jones, are you doing okay? I'm still right here. That way they have their privacy. If they're completely confused or they've lied to me before and I thought that they were completely with it, but then they tried to stand up and I had like a scare with them, then I'm just saying, I'm sorry, I have to stand here with you. I have to keep you safe because ultimately I'm responsible for them. So I have to treat them like I would want someone to treat my mom if she was in the hospital, and you have to keep them safe. So it's kind of like give and take. Give them privacy when you can, making sure that they're in a good position to pee. So like I said, making sure that you can assist the guys to stand up so they can use the urinal. Some patients might not be able to go on a bedpan. Get that bedside commode next to the bed. So they just have to do a stand and a turn pivot, and they'll be on the bedside commode. And then always make sure we're doing good hygiene, cleansing them after they go to the bathroom. I see that happen all the time at the hospital. They pull someone off of a bedpan and then they throw their towel back, they throw their gown and they pull the covers back. And I'm like, really? You didn't even do any perineal care. There's like urine or stool, not usually with stool, but there's urine sitting on their, their genital area. So make sure you can even give the toilet paper to the patient. If they can't get out of bed and they can't get to the bathroom, they might be able to wipe themselves, and that might be a good feeling for them. They might feel like they're involved in their care. So give them the toilet paper, let them help as much as they can, because we don't want to have skin breakdown and we want to prevent infection. So UTIs, what are our risk factors? So sexually active women. During intercourse, there's certain perineal bacteria that can migrate to that urethral area and the bladder. And remember, with women, it's a very short span there. So that's why we're much more prone to get those bladder infections, and then it can progress to the kidneys. Women who use diaphragms for contraception, so the spermicide that's used with these diaphragms, decreases the amount of protective flora that we have in the vaginal area. So that increases your risk for infection. Postmenopausal women. So we said that decrease of estrogen occurs, contributes to that loss of protective flora in the vaginal area. And then you have urinary stasis, which is very, very common. And then when you have that urine in there, it's the perfect environment for that bacteria to grow. Patients that have an indwelling urinary catheter in place. So bacteria travels through or around the catheter and it goes into the bladder. UTIs are the most common type of healthcare associated infections in the hospital. Up to 75% of hospital acquired UTIs are associated with an indwelling catheter. So you guys will see in the hospital setting, most hospitals have a nurse protocol for removing the catheter. So as a nurse, if you don't think that your patient needs that catheter anymore, you can remove it on your own. You don't need an order to do it. And you don't have to put it in if you don't think that it is warranted. That requires more of a conversation with your doctor. But like sometimes if you have a patient who is retaining fluid, retaining urine, and you have to do a straight cath once and you get out 600 cc's, and then 5 hours later you bladder scan them and there's another 500. At that point, I'm not going to recommend that I do another straight cath. I'm just going to say, I think we should do a foley, because every time you go in and you straight cath them, you have that opportunity to introduce more bacteria. And if you think it's going to be a problem that keeps happening, then you want to just do the foley. Remember, we said that UTIs are never events in the hospital. It increases healthcare costs. It increases morbidity and mortality. Medicare will not pay for a CAUTI that happens as a complication of being in a hospital. Let's see. So another thing that we see is you want to think about if your patient has a Foley, when they're in the bed, you want to make sure that that urinary bag is always well below the patient's bladder so that the urinary bag can drain. If not, it's going to back up into the bag, or it's just going to sit in that area in the bladder and they can get a UTI from that. So you want to make sure, as nurses, we pretty much know that, but you want to watch your transportation people when they come to pick them up and they're taking them to a test. They don't always know that, and they'll put the patient on the stretcher and they'll throw that Foley bag right on top of their abdomen and send them off. And that little bit of time with that urine sitting in there, it can cause a UTI. So you just need to make sure that you're educating everyone else around you. Uncircumcised males, obviously there's a risk there for developing a UTI because that area is, that skin comes up and it's not cleaned properly. Patients that have diabetes, this causes a change in their defense system because of the diabetes, which causes an increased risk for UTIs. And then we know those older adults, right? It's those physiologic changes that they have that predispose them to the development of UTIs. And then men, as that prostate gets larger and larger as men get older, they're also more at risk for UTIs. Those people with diabetes and the older people, they get everything. So nursing considerations, make sure that we're cleansing our female patients from the front to the back, clean beneath the foreskin in males, and then make sure we are providing catheter care regularly. In the hospital setting, it has to be done once in the morning from 7 a.m. to 12 noon, and then once at night from 7 p.m. to 12 midnight. And it has to be documented. So what are some reasons that our patient may need a catheter? We use this to relieve urinary retention. It is usually temporary, and it can also be very common after surgery. If we delay ambulating our patient, if their fluid intake isn't normal, or if they've had some kind of epidural anesthesia used for pain control, we would have them, they would have a Foley. Sometimes postpartum moms need to have a Foley longer than normal because they have swelling from the delivery at that site of the meatus, and it won't allow urine to get through. Those men with enlarged prostates, they have a lot of retention. If they have a neurogenic bladder, maybe they've had a spinal cord injury, they usually have a neurogenic bladder, they would require a long-term use of an indwelling catheter. Those patients usually have a suprapubic catheter, which goes on the outside of their bladder area. Sometimes we need to obtain a sterile urine specimen from a patient that is unable to voluntarily void. So we'll go in one time and do that intermittent straight cath. It's not a Foley, we just go in one time. It's a sterile procedure. We grab the urine, we send it off. If we have a patient who's incontinent and we need an accurate measurement of urinary output if they're critically ill. So if they are in an ICU or in a SICU, some kind of a higher level care unit. Maybe they have pressure sores in their sacral area or perineal wounds, and they're incontinent. We will put in a Foley then because we want to keep that area as clean as possible to prevent infection. If we need to empty the bladder before, during, or after certain procedures, or before certain diagnostic examinations, we do use Foleys at the end of life to provide comfort for our patients. It decreases the amount of times we have to roll them and clean them because they will be incontinent. And then if a patient's going to be, they're going to be immobilized for a prolonged period of time, if they've had some kind of thoracic or a lumbar spine surgery, or they've been in a motor vehicle accident or something like that, and they're not going to be moving, then we would also give them a Foley. So the types of urinary incontinence. Stress incontinence is very common. It's the loss of small amounts of urine from increased abdominal pressure without bladder muscle contraction. So with laughing, sneezing, or lifting. We have urge incontinence, which is the inability to stop urine flow long enough to reach the bathroom due to an overactive detrusor muscle with increased bladder pressure. And you can have mixed incontinence, which is symptoms of urgency and stress together. You can have overflow, which is urinary retention from bladder over distension. And then you have frequent loss of small amounts of urine due to the obstruction of the urinary outlet, or you could have an impairment with that detrusor muscle. Functional incontinence is loss of urine due to factors that interfere with responding to the need to urinate. So this is your cognitive function. So you have a loss of memory, or you're disoriented, mobility, if you have some kind of physical limitation, or any type of environmental barrier. So think of the patient who lives at home and has impaired mobility, and the bathroom's on the second floor. Those are barriers. Reflex incontinence, which is involuntary loss of a moderate amount of urine, usually without warning due to what they call hyperreflexia of that detrusor muscle, which is usually seen in patients that have spinal cord dysfunction. And then we have total urinary incontinence, which is very unpredictable. It's involuntary loss of urine that generally does not respond to any treatment. So factors to consider when using absorbent products. So patients usually turn to absorbent products when they're incontinent, and they've never had this issue diagnosed or treated. When they use it improperly, it can cause incontinence. It can cause incontinence associated dermatitis. So when that urine is not pulled away from the skin and it sits on the skin, you can get like a red rash. It can further progress to skin breakdown. Our urine is very, very acidic and it is very hard on our skin. This also puts our patients at risk for developing a UTI because all that urine is just sitting there and it's growing bacteria and it's so close to that area. So if there's functional disabilities of the patient, they might consider using absorbent products. Depending on the type and the severity of incontinence that they have, their gender, what's the availability of caregivers? So if they can't get to the second floor to go to the bathroom and they dribble sometimes throughout the day and there's no one there to, maybe they only have someone there in the evening or just someone there in the early morning with them and they spend a good part of the time in the afternoon by themselves. Maybe they're going to wear a pad just to help with that dribbling. If they've had failure with previous treatment programs that would address incontinence, and then sometimes it's just a patient preference. The thing to think about with absorbent products is that they're being changed constantly. And then if you have a patient that's immobile, like in the hospital, we would never put a diaper on a patient that's immobile because that is constantly sitting against the skin. It's not being pulled away. It's going to cause infection. It's going to cause skin breakdown. It's just a bad situation. So we just use the absorbent pads in the hospital. And then you might have a patient that has a urostomy. We're not going to talk a whole lot about this. A urostomy is a procedure where they bring the ureters and they create this little stoma on the outside of the skin. And it connects to this bag here, and that's how the urine comes out. So this is what we call incontinent urinary diversion. We can do that to deal with incontinence, and then we're just changing this bag every day, and we can do it for a variety of different reasons. So this is what a urostomy looks like, and this is the little stoma. Oh, you guys don't have that slide. Oh my God, hold on, I want to show you these. I'm sorry, I thought you guys had that. All right, so this is the stoma. This is where it comes on the outside of the abdomen. They just bring the ureters out and then they use the mucus membranes to create this little stoma. This is what the stoma looks like. We're going to talk more about these when we talk about stool in a couple minutes with colostomies, but they should always be nice and bright, beefy red and very moist. And this is the bag that we would use that we attach to the patient. It collects the urine. Sometimes at the very bottom, there's a thing that unfolds and you can empty the urine from there, or sometimes you just have to change the bag frequently. It just depends on what type the patient has. Okay. All right, so I have a couple questions for you guys. Hold on, I'm going to have to share my screen because you guys don't have these. Okay. So incontinence that results from weakness of the pelvic floor muscles is called blank. It can be treated by teaching the patient to perform blank exercises. So I'm going to call on somebody. Raven. What is incontinence that results from weakness of the pelvic floor muscles called?
Is it reflex?
It's not reflex. It is, who else? Let's try somebody else. Brianna? What do you think? You can look at your slides. You still have them.
Still have them up. Incarnate. Weakness of the form. I know we do Kegel exercises for it.
Yes. Yes. very
I know
good.
the one part. But it's not functional loss, but.
Okay, who else? Who knows what type of incontinence it's called? Shanoa.
Stress.
Stress. Very good. Good job. All right. What laboratory test shows that concentration of all chemical particles in the urine? Is it urine-specific gravity, Bunn, creatinine clearance, or D-dimer? I'm going to call on somebody. Alan. What do you think? The laboratory test that shows the concentration of all chemical particles.
I'll take A.
Which one?
A.
Did you say B?
No. I say A.
A, yes, very good. Urine-specific gravity. Bunn and creatinine clearance look at kidney function, and D-dimer looks at whether or not you're having a blood clot in the body. So it doesn't even have anything to do with urine. All right, a urinary blank involves the surgical creation of an alternative route for the excretion of urine. We just talked about this. What was that? A urinary what? Let's see. Monica. A urinary what? Involves the surgical creation. Remember, we comes on the outside of the belly. We attach a bag to it. The urine goes in the bag. What do we call that little red area? You can look in your slides. What is that little red area?
Is it okay? I can try.
I can't hear you. Did you say something, Monica? Oh, for some reason I can't. Did you say stoma? Okay. I can see your mouth moving, but I couldn't, for some reason it's not coming through. Good job. Very good. All right. And then this last one, a nurse documents that a patient has anuria when the 24-hour urine output is less than 400. Is that true or false? Kelsey Ziegler.
I knew you were gonna call it. That's false.
Very good. What's the right amount? What constitutes anuria?
Urea is when you don't have any in your bladder. You don't have any urine.
It's when your urine output is less than 50 mLs in 24 hours.
Because one of the questions on the things was like, there's no urine in the bladder. Did anybody else get that on the questions today for the what should we call it? The course point. Yeah, it was like, what is this when there was no urine in the. So it didn't give a number, I guess, is what I mean, I just knew that it was very none.
Right. Okay. Very good. All right. So now we're going to go to bladder. to bowel. We already did bladder. Now we're going to bowel.
Miss Davis,
Yes.
in a second, my kids gonna come back home, so I'm gonna just take myself off the camera to go open the door.
That's fine. Thank you. Okay, so what are our objectives? We want to describe the physiology of bowel elimination. We want to identify variables that influence bowel elimination. We want to assess bowel elimination using the appropriate interview questions and physical assessment skills. We want to assist with stool collection for laboratory analysis and direct and indirect visualization studies of the gastrointestinal tract. We want to identify appropriate nursing interventions to promote regular bowel habits and plan nursing care for a patient with an ostomy. So the exemplars that we're going to cover are constipation and diarrhea. Whoops, I did it again. All right, so this is again just a review, anatomy and physiology. You have the duodenum, your ascending colon, your transverse colon, your rectum, your appendix, your all this good stuff. Should just be a review of where everything is located. Whoops. Hold on. Okay. So the large intestine. So the large intestine is the primary organ of bowel elimination. It is about 5 feet in length, about 1 inch wide. It extends from that ileocecal valve all the way over to the anus. If you go back to your picture, yep, you can see it there. It goes all the way around. It functions with the absorption of water. So it pulls in water, it manufactures some vitamins, it makes vitamin K and certain B complex vitamins, and it helps the formation of feces. Once excreted, our feces are then called stool. When they're inside, they're called feces. About 800 to 1,000 mLs of liquid is absorbed in the large intestine on a daily basis. If we have decreased absorption, which means it's going to rapidly pass through, our stools are going to be soft and watery. If we have increased absorption, so it's too long in the intestines, too much water is absorbed, our stool is going to become dry and hard. All right, so the anatomy and physiology. So our stomach is a hollow J-shaped muscular organ that is located in the upper right portion of the abdomen. It stores food during eating. It secretes various digestive enzymes and fluids. It churns our food to aid in digestion, and it pushes the partially digested food called chyme into the small intestine. Our small intestine, we said, is 20 feet in length and 1 inch wide. It also secretes enzymes that digest certain proteins and carbohydrates. There are digestive juices from the liver and the pancreas that also enter into the small intestine. That comes through the duodenum. And then the small intestine is responsible for digestion of food and absorption of nutrients that then go into the bloodstream. So our peristalsis is under the control of our nervous system. The autonomic nervous system innervates all the muscles of the colon. The parasympathetic nervous system stimulates movement, while the sympathetic system inhibits movement. So in order for peristalsis to happen, we have contractions of the circular and the longitudinal muscles of the intestine, and that's called peristalsis. We have contractions that occur every 3 to 12 minutes. We have what's called a mass peristalsis sweep that occurs 1 to 4 times in every 24-hour period, and it propels the fecal mass forward to continue to go through all the rest of the intestines. This mass peristalsis usually occurs after food has been digested, which then pushes everything through and causes that urge to defecate. We have flatulence, which results from distension of that bowel. When the bowel distends, you get air in there, which causes gas accumulation. Sometimes you can cause cramping, or you can have a feeling of fullness. You might be bloated. 1/3 to 1/2 of all food waste is excreted in our stool within 24 hours. So this is that hold on 1 second for me. Sorry, guys. Sorry about that, guys. My husband was locked in the garage. My son locked the door. Okay, so this is the peristaltic movements through the intestines. You can see how those little cramps, and they squeeze and they help propel everything along. So what are some of the factors that affect bowel elimination? So there's a lot of them. So developmental considerations, pretty much the same thing that we discussed with, you know, those newborns, the babies, you know, when they're little and they're infants, their poop is not really formed. It's yellow, it's seedy. As they start to get older and their diet changes, it becomes more formed. And then we progress into when we start potty training them. But like we said, they have to be able to meet certain milestones before you can do that. When we talk about activity and muscle tone, regular exercise, it helps to improve gastrointestinal motility. It helps with your muscle tone. So we know if exercise is good for those, then we know that inactivity decreases both of those. So these are things that we see in patients who are immobile or who stay in bed. This is why we want to educate our patients to get out of bed, walk the unit, go sit in your chair. You need adequate tone in the abdominal muscles, the diaphragm and the perineal muscles, to be able to defecate with ease. Patients that are on prolonged bed rest are prime candidates for constipation. Your lifestyle, so there's many different things in our lifestyle that affects bowel elimination. There's just individual factors, what we eat, how often we go to the bathroom, family, socioculture variabilities. Some people like to talk about it. Some people never, ever talk about it. And some cultures see it as a very dirty process and have to go through certain cleaning rituals when they go. So lifestyle, there's a lot of different variable things there. Psychological variables. So anxiety has an effect on gastro motility, usually causes diarrhea. With high periods of when you're anxious about things or upset about something, you see that fight or flight response. So the body mobilizes itself for intense action. They shunt all the blood away from the stomach and the intestines, which results in a slowing of gastrointestinal motility. Some people just have a nervous stomach, and when they get upset, then they have diarrhea. There's pathologic conditions, so changes in, if you have a major change in your stool characteristics, it can also be a clinical manifestation of another type of disease. So if a patient reports all of a sudden that they have what they call ribbon-like stools. So ribbon-like stools are very, very thin, very, very long, and they look like ribbons. That occurs in patients that have tumors or colon cancer because the stool is going around that tumor and it's smushing it and making it very narrow. If they all the time were never ever constipated and now they go back and forth between constipation and diarrhea, that can be irritable bowel syndrome, a lot of different disease processes. So diagnostic studies, some patients, depending on what they're having done, they might need to fast. We give them, some of them have to drink barium during a procedure. If we do not completely eliminate that barium out of their system after the procedure. It can cause constipation or an impaction. So you need to make sure when they come back, sometimes they'll get a bag of IV fluids if they're not capable of really drinking a lot of fluids. If they can, you just want to encourage them for them to take a lot of water to help wash everything out. Sometimes the stress of being in the hospital, being sick, when you're thinking you're waiting for different results, you just want to go home, you don't feel good, combined with changes in food intake, maybe you have food you don't like, this can certainly have an effect on your elimination patterns. If you're not eating because you don't like the food, what doesn't go in can't come out. Maybe you're nervous because you're waiting for results, that's giving you diarrhea. So there's a lot of different things. Surgery and anesthesia, there's some times where they have certain procedures that directly manipulate the bowel, and it can cause, it can inhibit peristalsis. It can cause what's called a post-operative paralytic ileus that lasts for 3 to 5 days. Usually, if they have an inhaled general anesthetic for certain surgeries, that can inhibit peristalsis. So we said when we put patients to sleep, it puts everything to sleep. So these patients are more at risk for developing constipation. And let's see, I think this is everything that we just talked about. Let's see. So daily patterns, we talked about developmental. Daily patterns, most people do have an individual pattern. Some people will drink a cup of coffee and go every morning. Some people have to go as soon as they get up every morning. Some people go at night. That's completely normal. Some people go once every 3 days. That's completely normal to them. Everybody has a pattern. If you have the urge to defecate and then you ignore it because you don't have the right place or the right time or it's inconvenient, then the feces stay in the rectum until defecation, till that defecation reflex is initiated again. But then what happens, meanwhile, the water still continues to be absorbed from that unexpelled feces, which makes the stool dry, hard, and painful to pass. So you should not hold your stool. But there are some people who will never poop when they're out. They just can't poop in other people's bathrooms. They can't poop at the store, so they just can't go, so they hold it. So holding it, you just want to educate your patients that if they hold it, it can certainly contribute to constipation. So always try and keep a regular elimination schedule if you can. So there are certain foods that affect bowel elimination. So both the amount of food that we take in, the amount of fluids we take in, and then the type of foods and fluid, they both have an effect on elimination. So a high fiber diet of at least 25 to 30 grams of fiber daily is recommended, along with a daily fluid intake of 2,000 to 3,000 mLs of fluid a day. I think we said back in urinary elimination, it was 2,000 to 2,400. It's an estimate. High fiber foods, these are your whole grains and your bran, dried peas and beans, fresh fruits, fresh vegetables. These increase the bulk in your fecal material. Bulkier feces increases the pressure on the intestinal wall, which serves as a stimulus for peristalsis. What happens is the feces move more quickly through the colon, allowing less time for water to be reabsorbed. So if that happens, the stool is soft and easy to pass. When the stool moves quickly through the colon, there's also less time for toxins to be absorbed from the feces by the colon. There's been different studies that have been put out that show that they believe that these toxins play an important role in promoting the development of colon cancer. So it's another reason for you to make sure you're having frequent stools. You want to avoid constipated foods like processed cheese, lean meats, eggs, pasta, rice, white bread, iron, and calcium supplements. These are all constipating substances. Foods that have a laxative effect. So there's certain fruits like prunes, your vegetables that are fresh, high fiber bran, chocolate for some people can be, alcohol, coffee can be, spicy foods, whole grains, and dried beans. Your gas-producing foods are onions, cabbage, beans, cauliflower, eggs too, and broccoli. And then we want to look at lactose intolerance. So patients that cannot tolerate lactose, so they can't have dairy. So they lack the enzyme lactase. They can't break it down. It breaks down simple sugar, which is found in the lactose, which is found in milk. They can't do that because they lack that enzyme. So patients have intestinal gas, diarrhea, bloating. Sometimes it's very mild. Sometimes it's very serious. I know my daughter's lactose intolerant, and every summer she has to go up to Broom's Bloom and she has to get and she's always with me, and she has to get one of their ice creams or their milkshakes, even though she knows she's lactose intolerant. And by the time we get home, she's ready to poop her pants because it just goes through her just like that. So everybody's different, but she keeps having it because she likes it. But there's also pills you can give your patients too. If they like that kind of stuff and they want to have it, they can take these pills that help them be able to, take the place of that enzyme and actually tolerate the lactose. So we know that certain medications can also have an effect on stool. So aspirin or your anticoagulants, they thin the blood. So you can always have the risk of having a GI bleed. So you could have pink to red blood or black stool. Black stool usually comes from upper GI issues, older blood. Bright red is a lower GI bleed or an active bleed. Certain opioids, so morphine, Dilaudid, these decrease your GI motility and they cause constipation. Different irons will cause your stool to be black, something you want to educate your patients about. Antacids can cause a white discoloration or a speckling in the stool. Sometimes it'll look like chalk. It contains things that contain aluminum, iron sulfate, and anticholinergic medications also decrease that GI motility. Sometimes patients that have magnesium replacements, they will complain of diarrhea. Metformin can cause diarrhea. Metformin is an oral hyperglycemic that we give to patients who are just diagnosed with diabetes. Then we have Colase and stool softener. So the purpose of Colase is to soften the mass of stool and make it easier for them to eliminate it. So it pulls water in, makes it softer, and they can makes it easier. Certain antibiotics, so this is an important slide, you guys need to know this. Certain antibiotics can cause diarrhea. It can cause your diarrhea to be green or a gray color. When we give patients antibiotics, it destroys the normal intestinal flora that you need to promote good stools. It can cause nausea and vomiting and diarrhea. So we need to encourage our patients to intake fermented dairy is one way. So we can encourage buttermilk or yogurt if they do it in their diet, or if they can't tolerate if they can't tolerate the yogurt or they don't like yogurt, then you can give them a probiotic in a pill form. Let's see. All right. So nursing process, the physical assessment. So we are going to check the skin very, very good for any kind of irritation that would be secondary to diarrhea. So even our patients that are up and mobile that can get to the bathroom can still have skin breakdown because they're having diarrhea so often. If you've ever had diarrhea and you keep wiping and wiping and wiping, your skin can feel raw. So you want to make sure that you're checking on them, offering them cream. Super important to pay attention to your patients who are not able to move, who are stooling on themselves. You want to make sure you're changing them as soon as possible, assessing that skin, putting on moisture barrier. If patients have liquid diarrhea and they have wounds, maybe they need a fecal management system. Or if they're just putting out high volumes of liquid stool, a fecal management system is still warranted. It's kind of like a catheter for the for the rectum. It's a tube that you wrap around your finger. You insert it into the rectum, you push it in, you insert air into it, it blows it up like a balloon, and then it seats in the neck of the anus. And then any stool that goes in the tube and it collects in a bag.
Ms. Davis,
Yes.
can I ask a question, please?
Can we wait till the end?
Oh, okay.
Hold on to your question, just because some people don't stay after, and I don't want to run over.
Okay.
You want to inspect their abdomen. Look for any contours, any masses, any distension. These are all signs of impaction or constipation, or it could be anything that's going on there. They could have a colon mass, they could have any kind of mass in their abdomen. So just make sure you're looking at the abdomen area. You want to inspect their anus and their rectum. Now, these are not on healthy people, okay, that don't have any issues. You're not going to ask to see their anus or their rectum, but this is your incontinent people, or if a patient complains of hemorrhoids or some type of a problem there that would cause you to look. You want to examine the anal area for any kind of cracks, any kind of nodules, distended veins, masses. Polyps are usually on the inside. I've never seen one on the outside, but I guess it's possible, or any kind of mass. You want to inspect that perineal area really good for skin irritation. You want to ask the patient to bear down as though they're having a bowel movement, and then you can look for any kind of anything that comes out of the rectum. So in those hemorrhoids, fecal masses, anything like that, and then you just inspect the perineal area. Really, 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 really good for skin irritation. Constantly reassessing that perineal area. So when we're auscultating, we're listening for bowel signs in all quadrants. We're starting in that lower right quadrant, moving up to the upper right quadrant, over to the left upper, and down to the left lower. Make sure you listen in that way. You're going to listen for the frequency of sounds, the character of sounds. If you hear any clicking noises or any kind of gas. We know that normal bowel sounds are high-pitched. They can sound gurgly, and you're going to hear between 5 and 30 in a minute. That is considered normal. Anything less than 5 is hypoactive. Anything greater than 30 is hyperactive. Percussion, we don't do percussion. Palpitation, you want to note any kind of muscular resistance if you're palpating, if they have any tenderness, if you can feel the enlargement of any organs, if you feel any masses. Sometimes if your patient is really constipated or they have a blockage somewhere, you can actually feel the stool through their stomach. So collecting a stool sample. There is a nursing process for collecting the stool sample. You always want to make sure that medical aseptic technique is imperative. This is important. You guys need to know this. You want to make sure you do hand hygiene before you put on your gloves and after you put on your gloves. It is essential. Wear disposable gloves. Do not use the same gloves that you picked up to poop with to put inside the container and put the lid on. What I do if I'm collecting a stool sample and I think I'm going to use my hands, because sometimes you have to use your hands if that's the only way you can get it. I put on 2 or 3 pairs of gloves. I'll go in, I'll have my container in one hand. If I have to reach in to grab a sample, I'll pick it up, I'll put it in, I'll pull that glove off. Then I can grab the lid and put it on, and I wipe off the bottle before I send it out. So make sure you're not contaminating that outside area and then touching it with your hands when you're carrying it to send it off. Make sure that you have the proper packaging, depending on what type of test you're having. Label it with your patient's information and send it according to your agency's policy. If you're doing a stool culture and they're looking for some type of an infection from a bacteria or a certain virus or a parasite, make sure that you send that off before you start your treatment, your antifungal treatment, your antiviral treatment, or your antibiotics, okay? Because that's going to affect your culture if they've already been started on the antibiotics. And then if you were looking for blood, you would do an occult blood test. We do these in patients that we suspect have bleeding ulcers or some type of inflammatory bowel or colon cancer where there would be blood present. All right, so just like the urine samples, you do not want to contaminate your stool sample with urine. They need to be completely separate. You want them to defecate into a container rather than the toilet bowl, if it's possible. Do not place toilet tissue in the bedpan or the specimen container. You want to throw it to the back of the toilet. Make sure that you tell your patient that they need to notify you or the tech as soon as that specimen is available, because you don't want it to sit there. You want to grab it, make it as fresh as possible. And then remember those 2 essential techniques. You need to hand wash before and after you wear your gloves. That's important. All right, so what are some diagnostic tests that we can do? We can do that fecal occult blood test that looks for blood. You can do endoscopic procedures. Endoscopic procedures are when they go down, they put you to sleep and they look down your throat and they visualize your stomach. And then you can do barium studies. These should always go before your upper GI series. These are non-invasive procedures that take precedence over invasive procedures. So you always want to do your non-invasives first and rule out things. And then if you have to do a more invasive procedure, then you do it. So we have 2 types of an upper GI series. There is a standard barium, which just uses barium, and then there's a double contrast upper GI series that uses barium and air. And it just helps to give a clearer view of the lining of your stomach. So you can look at page 1430 to 1431. There's a nice chart there that talks about different studies. So we have indirect visualization studies. So we have the small bowel series, which is a fluoroscopic examination that looks at your esophagus, looks at your stomach and your small intestine after you swallow barium sulfate. It helps visualize everything. We can do a barium enema, which is a series of radiographs that examine the large intestine after they instill some barium sulfate into the rectum. We can also do an abdominal ultrasound. It uses ultrasound waves to visualize all those different organs. We can do a MRI. This provides physiologic information and very detailed information of different anatomic views of tissues. It's very detailed. And then we can use an abdominal CT scan, which takes different X-ray beams that are directed at different parts of the abdomen, and it gives you a clear picture of certain anatomy that you're looking at. So the endoscopy. So you can do a colonoscopy, which goes through the rectum, that visualizes your rectum, your colon, and your bowels using a lighted scope. You do have to be asleep for this procedure. You can do the EGD, which examines, like we said, the esophagus, the stomach, and that upper duodenum. It looks through an optic scope that goes down your throat when you're asleep. You can do a sigmoidoscopy, which examines the distal sigmoid colon, the rectum, and the anal canal. They use this by using a sigmoid scope, which is flexible, so it goes around all the different areas. And then we can use an upper gastrointestinal series. I think we talked about that in the other slide. It's where the patient swallows the barium sulfate, and it gives you a good picture of the esophagus, the stomach, and that small intestine. So some of the nursing diagnosis that we might see, we might have deficient fluid volume related to prolonged diarrhea, impaired skin integrity related to prolonged diarrhea, fecal incontinence, ineffective coping related to the inability to accept a permanent ostomy, risk for constipation, Our outcomes may be that a patient has a soft formed bowel movement every 1 to 3 days without discomfort. The relationship between bowel elimination, diet, fluid, and exercise is explained to the patient, and patients should seek medical evaluation if changes in stool color or consistency persist. Okay. So how do we promote regular bowel movements? Well, timing. We can encourage toileting throughout the day. Ask the patient to explain what measures are most successful in maintaining regular bowel function at home. Some people might tell you that they have to take Miralax every day. Some people might say that they take 2 Senna. And if that's not ordered, make sure that you call the doctor and say, hey, look, Mrs. Jones usually takes Miralax every day. It's not ordered. Can you please order that? You want them to continue with whatever they're used to doing at home. And then make sure that you offer the assistance that they need. So if they need help getting to the bathroom, make sure they have a walker or a cane, or make sure that you're there to help them. If they prefer a commode or a bedpan, make sure you have those in the room. Positioning is important. You cannot, you can have a bowel movement laying down. It's not ideal. Sitting upright on a toilet and a commode promotes the easiest type of defecation. If you have to use a bedpan, you have to use a bedpan. Usually what I like to do is, if I can, I lay my patient flat, put them on the bedpan, and then I sit the bed all the way up into the high Fowler's position. So then they're kind of semi-sitting. Provide privacy if you can. Most people consider this a private act. They don't want anyone watching them, but as long as your patients, if they're a high fall risk, you won't be able to do that. Nutrition, make sure that they are having that good intake of fluid and a high fiber diet. Make sure that they're going to be exercising, right? We said exercise improves gastromotility. Let's see. And then we can do bed exercises that are helpful for patients who are immobile. So we can do something called abdominal setting, which is where the patient is lying in a supine position. They tighten and they hold their abdominal muscles for 6 seconds, and then they relax them. And we recommend that they do this several times every hour that they are awake. So it helps improve those abdominal muscles. And then we can do thigh strengthening, which is where the thigh muscles are flexed and contracted by slowly bringing the knees up to the chest one at a time, and then they slowly lower them back down to the bed. And again, we recommend that they do it several times for each waking hour. Helps build strength. So what is constipation? So decreased gastric motility slows that passage of feces through the large intestine. As it's going through and it's slow, it's taking longer to get through, this results in increased fluid absorption, causing dry, hard stool. So constipation is a bowel pattern of difficulty and infrequent evacuation of hard and dry stool. It can cause abdominal bloating and cramping. It can cause straining at defecation. And then it's usually noticeable because the presence of dry, hard feces is seen when they actually have a bowel movement. So we see this on patients who are on bed rest. That motility isn't moving. We see this with patients taking constipating medications. So opioids are narcotics, antacids that contain aluminum. That iron sulfate is very, very, very constipating, and anticholinergic medications. Clients that have a reduced fluid or bulk in their diet, clients who are depressed, clients with central nervous system disease or local lesions that cause pain. They might not have control. They can't release their bowels because they don't have control because they have that central nervous system disease. We can use laxatives, certain drugs that induce the emptying of the intestinal tract. We can use cholase, also known as docosate sodium. We talked about that earlier. That eases bowel evacuation, and it helps the related discomfort associated with stools. And then you can use Miralax, which helps pull water into that intestine to promote a bowel movement. We have osmotic laxatives and stimulant laxatives. An example of those would be milk of magnesia. Usually if a patient is constipated and they're alert and oriented, I ask them what they take at home when they're constipated, because usually they know. If they've never been constipated before, then it's usually up to the doctor and they try a couple different things. Okay. Oops. All right, diarrhea. Diarrhea in adults is considered the passage of more than 3 loose stools a day. That's what we call diarrhea. It's important to determine the consistency of the stools because frequent bowel movements alone are not always indicative of diarrhea. If they're going 3 or 4 times a day and it's formed, then it's not diarrhea. Patients with diarrhea usually pass more stools frequently. Diarrhea is usually associated with intestinal cramping. Sometimes they might have nausea and vomiting. Sometimes there's blood noted. When we look at our patients that have reported frequent, if you have a patient that says, you know, I've been having diarrhea all night, that's why I came to the hospital. I've had 6 bowel movements, it's all been water. What do you think is a type of a diagnosis, a nursing diagnosis that we could give them related to the diarrhea? Patricia.
Yeah.
What you say, Ms. Davis?
I said if we have a patient that has frequent watery stools, okay, over a certain period of time, what is one type of nursing diagnosis that we could give them? Thinking
So
about when we're more so thinking about the physiologic effect that it's going to have in the body.
they're going to be dehydrated.
Yes, so, but what's very good. What nursing diagnosis can you give for dehydration? What is dehydration?
Dehydration is not enough fluid in the body.
Yes, it's not enough fluid volume. So,
right.
So if they have dehydration, it would be what's the nursing diagnosis I'm looking for? It's something fluid volume.
Decrease. So dehydration and low fluid volume leads to falls.
It does lead to falls. The nursing diagnosis that I'm looking for is deficient. So deficient fluid volume. Yep, deficient fluid volume. Very good, Patricia. So these are things that you want to recognize. When your patient reports to you that they've had many watery stools, this is where your critical thinking comes in. You start thinking like a nurse. Well, my patient's having a lot of diarrhea. They are at risk for becoming dehydrated. So how can we tell if our patient has decreased fluid volume? What's their skin turgor going to look like?
So it's going to be less than 3, right?
It's going to
less
be
than 3, and it's going to be hypotension.
So when we talk about decreased skin turgor, so if they're dehydrated, when we take their hands and we pinch it like this, when we let it go, and a person that's completely hydrated, it goes right back down, it springs back down. If they are dehydrated, when we pinch it like this, it's going to stand.
So it's greater.
It's going to be tented.
Yeah.
But we call that decreased skin turgor. Their urine's going to be more concentrated. Their blood pressure can be low, right? Because these are all signs of deficient fluid volume. So these are the signs and symptoms that I want you guys to know, okay? Acute diarrhea can be caused from, it can be a viral infection, a bacterial infection. It could be caused by a certain medication. It could come because of an alteration in your diet. Usually comes on pretty sudden. It can last several days. Chronic diarrhea lasts usually for 3 to 4 weeks. You usually see these from inflammatory bowel diseases and irritable bowel syndrome. We can always give anti-diarrheal medications to our patients, except we cannot give them before we rule out C. diff. So if your patient is on antibiotics and they get C. diff, which is this terrible, bad, very, very contagious diarrhea, if they start having loose stools, you have to send off a stool culture first to rule out C. diff. Once that comes back that it's negative, then you can start giving them anti-diarrheal medications. As nurses, what do we want to do to treat that deficient fluid volume? We want to replace those lost fluids, right? So they're going to have IV fluids. They can have, if we're talking oral intake, they can have weak tea, water, bouillon cubes, clear soup, gelatins, Gatorades. We want to avoid highly spicy foods, foods with laxative effects, such as those raw fruits and vegetables. When your patient has diarrhea and they need help getting up, please make sure that you answer their call bells immediately, because you don't want them to stool on themselves or stool in the bed. You want to remove the cause of diarrhea. So if it's a medication, we want to stop the medication. If there's an impaction, you want to make sure that you obtain a physical order for a rectal examination. We don't usually do these. The doctors usually do them. Sometimes you can have a patient that has an impaction but has diarrhea because the stool around it becomes very thin and it actually moves around the obstruction. So your patient can be putting out a lot of diarrhea but have an impaction. Again, make sure you're giving special care to that perineal area, checking for skin breakdown, putting cream on, and then keep that bedside commode next to the patient's bed so they can get their, if they use a walker or something and they have really explosive, frequent diarrhea, they probably aren't going to be able to get into the bathroom. There's going to be diarrhea all over the floor, maybe all over you, all over her. It's going to be more work for you and it's going to be embarrassing for the patient. So get that bedside commode. If you have a patient who's ambulatory, a self, like me or you, and they're having diarrhea, that is the exception where I would allow them to wear a brief or a diaper in the hospital, because if they can get up and get to the bathroom on their own, sometimes they might dribble, but it's okay. They're not really filling their diaper up and it's not sitting on their skin. If they have to work with PT or they're going off the unit for a test, you might want to put a diaper on them for that purpose, but definitely contraindicated in that patient who's not up and mobile. We want to teach about food safety, because not handling food in a safe way can cause diarrhea. So we don't ever want to buy food with damaged packaging. If we get home and we notice it's been damaged, we want to throw it out. We never want to use raw eggs in any form. We never want to eat ground beef uncooked. Never cut your meat on a wooden surface because it's hard to get that bacteria out of the wooden surface. It's never really cleaned. Do not eat seafood that is raw or has an unpleasant odor. With anything, ground beef, chicken, seafood, if it smells gross, throw it away. Make sure you clean all your vegetables and fruits before eating. Refrigerate leftovers within 2 hours of eating them. And when you're thinking about children, only give pasteurized fruit juices to small children. But like, how do we even survive? Like, as a kid, I always ate raw ground beef. I mean, I always had raw eggs. People still eat raw eggs. I don't know how we even survived. And God, if we have like a family get together or something, our leftovers sit out for 5 or 6 hours. So that's just a guideline. Okay, so methods for emptying the colon. So sometimes we have to, like if they're having a colonoscopy, sorry, I forgot to turn it. If they're having a colonoscopy, we need to make sure that their colon is completely empty so we can visualize everything through that procedure. So we could do an enema. An enema is where we introduce a solution into the large intestine to remove feces. We can also do it to instill certain medications. Sometimes we do a vancomycin enema to instill medicine in there to help with C. diff. Enemas should be avoided in those with bowel obstructions or paralytic ileuses because they can increase the risk of a perforation. We do rectal suppositories. It's a substance that is shaped to be easily inserted into the body cavity, into the rectum. It's designed to melt at body temperature, and it can increase and produce a bowel movement. Or you can use, sometimes we use Tylenol suppositories for fevers and pain. We can do an oral intestinal lavage, which it's an oral solution such as what we call Go Lightly, which is similar to Muralax, but in a stronger fashion. We use these to, right before we do colonoscopies, to completely cleanse out the entire colon. It's considered a bowel prep. And we can do digital removal of stool, regardless of what you think. You as a nurse can do a digital removal. So our patients that have spinal cord injuries, they don't feel the need to go to the bathroom, their muscles don't work. They can't have a bowel movement on their own. They have to be digitally disimpacted every day. Some patients with Parkinson's disease, diabetes, certain malignancies, chronic kidney disease, they have issues with constipation. They might have to have digital removal. It is very uncomfortable if they have feeling there. And remember that it can stimulate that vagus nerve, which, remember when patients bear down and they do that vagal maneuver, it causes everything to slow down. So it causes that slow heart rate, can cause you to pass out. I've never done a digital removal ever. And I don't ever want to. I hope you
Well,
guys.
you just jinxed yourself.
I know. I did. I would so pay like a coworker to do it. I would buy them anything and make them do it. That's how nurses are. You always find there's always someone who loves mucus. There's someone who loves poop, and you just do what each other doesn't like to do. So it always works out. So this is, let me show you this picture. This is a picture of a digital removal that I found. So this shows you right here where the rectum is. So what you do is you insert your finger in there till you can feel it, and then you just start pulling it and breaking it into pieces until you can get it out, basically. All right, so the type of enemas. So we said we put this solution into the large intestine and helps remove feces. There are cleansing enemas, which help relieve constipation or fecal impaction.
Change the slide.
Oh, sorry. Sometimes we use these to prevent involuntary escape of fecal material during a surgical procedure. Never seen that done, never done that. Sometimes we do it to promote visualization of that intestinal tract because we're going to use, maybe have a colonoscopy, or we're going to do some type of x-ray. We help sometimes these help to establish regular bowel function when they're doing a bowel training program. I've never done a bowel training program. I don't know a lot about it, but I do know that they use enemas sometimes. The most common solutions that we see, especially in the hospital, are tap water. You have normal saline solutions. You have soap suds, and then you have what we call a hypertonic solution. So some of our retention enemas, which we put them in and the patient retains it because they're trying to achieve something. So sometimes we'll do an oil retention enema, which helps lubricate the stool, line all of that intestinal mucosa, which makes it easier to have a bowel movement. Sometimes there's carminative, which helps expel flatulence from the rectum if there's a buildup of gas. We can do various medicated enemas. And then there is an anthelmintic retention enema, which helps destroy intestinal parasites. I've never seen that or heard of that before. So our large volume enemas are about between 5,000 and 1,000 mLs. These are our hypotonic tap water and soap solution enemas. They have rapid colonic emptying, usually they work very quickly. Then we have our small enemas, small volume enemas, which is usually 70 to 130 mLs. These are our hypertonic solutions. They draw water into the colon, which stimulates the defecation reflex. And you can read all about enemas on page 1439. All right, nasogastric tube. So a nasogastric tube is a pliable single double lumen that is hollow inside. We use this for the removal of gastric secretions and the installation of solutions into the stomach. The gastric tube is passed through the nasopharynx into the stomach. It's inserted to compress or drain the stomach of fluid or unwanted stomach contents. And it is used to allow the gastrointestinal tract to rest before or after abdominal surgery and to promote healing. So, let's see, there is a video for you guys to watch.
Nasogastric tube insertion is a common procedure in the hospital setting. It is a useful technique for doctors and nurses to know and be able to perform. This DVD will demonstrate and explain the insertion of a nasogastric tube, as well as the anatomy of the gastrointestinal tract in relation to this procedure. This is a nasogastric tube. They are commonly made from polyurethane or silicone, as these materials are resistant to gastric acid. The tube is radio-opaque, which means it can be visualized on X-rays. You will see why this is useful later on. You can observe free flow through the tube in this demonstration. We can aspirate stomach contents using a syringe. Next, we need to measure the length of tube we will require to insert through the nose to reach the stomach. This can be conveniently estimated by using the tube to measure the distance from the tip of the nose to the earlobe, plus that from the earlobe to the transpyloric plane. Pass the tube calmly and slowly along the floor of the nose and into the nasopharynx. Stop if your patient is very uncomfortable or asks you to. It is a good idea to keep looking at the patient's face during the procedure to check they are coping adequately, or perhaps agree a sign if they are distressed. Once in the oropharynx, it continues its journey into the esophagus. The patient taking sips of water not only helps us to pass the tube more easily, but it also triggers the swallowing reflex to close the epiglottis and prevent passage of the tube into the trachea.
Okay. So these are really super easy to put in. It's one of my most favorite things to do. It seems pretty scary. Oops, hold on. But once you start, it's really easy to do once you learn how to do it once. All right, so that's the nasogastric tube. Then we have ostomies. So an ostomy, so sometimes a patient has to have a surgical procedure which creates an opening in the abdominal wall to get that fecal matter out because they can't, maybe they've had colon cancer, they've removed part of their colon for some reason. So when they have that surgical procedure and they form that opening, we call that an ostomy. So the intestinal mucosa from the inside is brought to the outside of that abdominal wall, and that stoma is attached to the skin. They bring that mucosa around the skin and they suture it. A colostomy permits formed feces in the colon to exit through the stoma, which is that opening of the ostomy that's attached to the skin. Colostomies are further classified by what part of the colon where they originate from. So an ostomy is surgically formed opening from the inside of an organ to the outside. That stoma is the part of the ostomy that is attached to the skin. The colostomy permits that formed feces into the colon to exit through that stoma on the outside of the abdomen. If you have a sigmoid colostomy, your stool is going to be solid. So where it is depends on the whether it's loose or it's formed. So a sigmoid colostomy, your stool is going to be solid. If it's in your descending, if it's a descending colostomy, it's going to be semi-formed to formed. If it's a transverse colostomy, you're going to have soft stools. If it's an ascending colostomy, you're going to have liquid to soft, and it's going to be a continuous drainage. So when I say continuous drainage, what happens is sometimes we have to change the bag that's on it, and your ostomy is just sitting out there in the open, and you have to clean around the area before you can put the new bag on, but it's kind of hard to do because it's constantly draining. It's just going to constantly be oozing out the whole time. And then if you have an ileostomy, it's going to be all liquid. So these are your pictures. So if you had a sigmoid colostomy, this is where your stoma is going to be on the outside of the skin. If you have a descending colostomy, your stoma is going to be over here on the left. If you have a transverse colostomy, it's going to be higher up here above your belly button. An ascending colostomy over here on the left lower. An ileostomy is going to be right about there in the middle. So this is a stoma. This is what your stoma looks like. It should be bright and beefy red. So this is your before and your after. So you can see where they took off a piece of that ascending colon and brought that stoma out over here. Here, if they took out part of that descending colon, and they would put the stoma right here on the left-hand side. So this is what they should look like. Red, moist, meaty, and very, very round. If they're pale, the patient could be anemic. They're not getting enough blood to that area. And if it is flush with the skin, that means that it has eroded. So these two you don't ever want to see. If you see them, you need to contact the doctor. So when we are taking care of these patients, we need to understand that they need a lot of physical and psychological support, especially people that have new stomas. You're going to want to think about that support and that education you're giving pre-operatively and post-operatively. Support can come from you, it can come from the doctor, the patient's significant others, family members, other members of the healthcare team, and even people who have had similar experiences. So you want to keep the patient as free of odors as possible. So that means you're going to want to empty that appliance frequently. We say that it's when it's 1/3 full to prevent leakage and explosions. And when I say explosions, I mean that if you do not empty that bag in time, it will explode and you will come in to find your patient and the bed covered in liquid stool. And I know that because it's happened to me. So always change it when it's 1/3 full. Make sure you're protecting that skin. So you should change the bag when it's leaking or when the skin around it doesn't look good, or according to your order. When you're changing that bag, you're going to look at that skin, make sure that there's no redness. You want to make sure that your bag fits and that your bag opening completely goes around that stoma, not too tight that it cuts off the stoma, but not too wide so that stool can sit on the open area of the skin and cause skin breakdown. Make sure that if they have a bag that can be emptied instead of changed, that you make sure that it's rolled up properly and clamped so that it doesn't leak all over the patient, and then control the odor. So sometimes these patients, they expel gas just like we do, but instead their bags blow up with air. So you have to go in and release the air out of the bag. And when you do, it smells horrible. Like you can smell it probably from 2 or 3 rooms over. If you're walking by a room and you've done that, you can smell it. It's very, very strong. So make sure you have the deodorizer around to minimize the smell to yourself, the patient, and then to other patients around. You want to make sure you're looking at that stoma regularly, making sure it's dark, pink, leafy red, and moist. You should note the size. Sizes can change when they first get it. Usually by 6 or 8 weeks, the size that it's going to be is the size it will be. Keep the stoma site clean and dry. Make sure you protect the skin. Measure the patient's fluid intake and output. If the patient does it themselves, make sure that they tell you how much it is so you can document that in the computer. Make sure you are thoroughly assessing the patient's self-care role. Is this something they're going to be able to do when they go home? Do they have someone at home to support them? Patient teaching is one of the most important aspects of colostomy care. So you want to make sure that you're including the family member and people who are going to be included in care when they go home, because it's a lot to cover and the patients will probably feel overwhelmed. So that's why we like to do a lot of that teaching before surgery, so that when they have this procedure, they can actually relate it to something and then they've heard this information before. And then you want to encourage your patient to care for and look at the ostomy. They might not want to. They might be embarrassed. They might be scared. Understand that the first day or two, they might not want to, and that's okay. But after day 3 or 4, you really want to get those patients involved. So you want to make sure that you're explaining the reason that they had this bowel diversion and the rationale for the treatment. This would be preoperative teaching, which they should already know because this comes from the doctor, but you want to make sure they know. Demonstrating self-care behaviors that could effectively manage the ostomy. So are they demonstrating them behaviors when they're in the hospital? Do you feel confident that they're going to be able to go home with their support system that they have and effectively manage this ostomy? If the answer is no, then they're going to need more education and they might have to stay in the hospital longer. You want to make sure that you describe any follow-up care that's needed and any support or resources that they will need. Make sure that that's in their discharge instructions. You want them to be able to understand where they can locate their supplies, where they can obtain them in their community, different resources. You want them to verbalize their related fears and their concerns. If they can verbally respond through education and talking with you, and they can tell you what's bothering them, then you can help them work through it so that they can effectively learn to manage their ostomy. And then you want them to demonstrate a positive body image. That might not come at first, but after they've had it for a while and they learn to go to work with it and they learn to manage it and they learn to conceal it and they learn that they can still do things and no one knows that they have it, then that body image starts to increase. So you want to encourage and recommend certain diets and exercise. They can exercise. We don't recommend contact sports, obviously, for the obvious reasons. You don't want to hit anything that can cause any damage. During the first 6 to 8 weeks after surgery, you want them to avoid foods that are high in fiber. So foods with skins, seeds, shells, any other foods that can cause diarrhea or excessive gas. So beans, cabbage, broccoli, eggs, cauliflower, Brussels sprouts, those simple carbohydrates such as white flour and potatoes. After that 6 to 8 weeks, they can gradually start increasing those foods until they tolerate them. We want them to drink at least 2 quarts of fluids, preferably water, daily. And then you might want to consider dietary considerations for patients with an ileostomy. If they have that diarrhea, they might need some type of supplement like an Ensure or something like that. Only use medications as needed. We know medications may discolor the stool and cause unusual odors. Some can cause constipation. Some may not dissolve or may be absorbed completely because of the small bowel is where most of the absorption occurs. So you want to think about that. Laxative and enemas are, sometimes you can do an enema. I've seen it done once, usually in extreme measures because they can cause severe fluid and electrolyte imbalance. And then you want to make sure when you are doing their dressing change, when they're taking that old bag off and putting that new one on, that you put that adhesive remover around it. It usually comes in little packets. It looks like alcohol pad. You open it, you put it all around, you wait for it to dry, and then you put your bag over top of it, and then it helps adhere to the skin, and then it makes it easier when you remove it, so it doesn't cause the patient any pain. And then sometimes if you're going to use a suppository, you want to use one that has an anesthetic in it because sometimes it can burn or cause the patient pain. You want to give them meals that stimulate their appetite. If they need help eating, make sure that you're helping them eat. If they need help actually eating, you can have a tech assigned to them or a CNA to go in and feed them. Make sure you can set their food up, make sure they can reach everything, and then provide nutrition in certain situations. Let's see, we do have one question. Let's see. All right, so which is the most appropriate nursing intervention to be implemented for a 50-year-old with diarrhea and a nursing diagnosis of incontinence related to sudden urgency with defecation? So do we want to assist the client to the bathroom frequently? Do we want to keep a bedside commode at the bedside? Do we want to promote answering the client's call signal, their call bell? Or do we want to put on a disposable brief on the client? Kelsey Fitzpatrick, what do you think?
B.
I would say D.
D.
I would say B.
So B is the answer. We want to, now we could put a disposable brief on them if they were completely, at 50, you assume that they're continent and they can get up and they can get around. We could do that. But in this case, the answer, because I did say that to you guys, you want to keep a bedside commode at the table, I mean, right next to the bed. You know that she has frequent diarrhea. It's sudden urgency. You want her to be able to get to the bathroom without defecating on herself or having an accident in the room. So we just want to make sure that they have that bedside commode. All right, guys. Let's see. We're done. What questions do you have? Oh, we still have.
I have a question. Oh, was somebody else talking?
No, it was me. Sorry.
No, it's okay, Kelsey.
Okay, go ahead.
So I have a question. I do my morning rounds and then I'm in the lab. What puts mucus in urine?
Infection.
Like
Like
super duper infection?
Like E. coli infection or an infection that just manifests uncontrollably. Yeah.
But that doesn't happen overnight, right?
Not usually.
No. Oh my God, you should have seen the urine I did today.
What did it look like?
Oh God. It looked like a slug.
Yeah, it's
Because
disgusting.
like we did like the urine culture and I couldn't even get anything through the tube because
yeah. And sometimes that comes out in the foley and you have to milk the tube because there's big. And what did it smell like, Kelsey? Could you smell it?
To be honest, I got COVID in March of last year and I still can't taste or smell.
Oh, lucky you.
So
Me too.
I get
Me too.
that, like,
Because it
he said me
stinks.
too.
It's bad. It makes you want to gag.
So everybody else in the lab is like dying and I'm throwing up, but I don't have the smell at least, but oh my God.
Yep. Any kind of infection
ridiculous.
can, yeah, any kind of infection can cause purulent drainage or pus, and that's no different.
But like, does it just pee out normally? Like, do you feel that? Like, or does it just kind of slide through like normal pee? How do you not know?
I guess, I mean, I would think that people like us would know because we would see it, but maybe your patients who have those long standing Foleys, them, you know, if they have spinal injuries, they don't know.
She's not a Foley though. Today, my patient wasn't a Foley. She was just a regular P.
Oh, well, God, I don't know then. Maybe she's not very observant, or maybe it just, she had signs and symptoms but didn't realize it, or they weren't that bad at first and then it just manifested into, who knows?
I just don't know how it gets to that tiny little hole, and it was a huge.
Oh, it hurts really bad.
Oh, okay, so it is painful.
Oh, it's very, very, very painful. Yes.
I feel like it'd be like a kidney stone type situation.
Yeah. It's bad pain. Yep, for sure.
Oh gosh, I'm sorry guys if I gross anybody up, but I just needed to know because I deal with that every day.
Yeah, it's gross.
And like that whole other thing that you said was like, make sure the lid's on and you label everything. I can tell you, I get bags of urine like in the cup, but the urine's in the bag because they don't shut the lid.
That's terrible.
So like we can't, they're like, oh, you can't take the urine out of the bag.
No, we're not doing that.
No, it's
Exactly.
the whole point of like a container.
Right. Oh,
so,
God.
yeah.
Quick question.
Sorry, everyone.
Oh, you're fine. No, it's fine. Are we going over the you said you're going to go over ATI, the website?
We are going to go over that, but we have to go over your our quiz questions first.
Gotcha. Thank you.
Before we do that, I have a question that I wanted to ask about the slides, but I don't want to forget about it since we can't ask during the slides. When you go back to